Bismillah ar-Rahman ar-Rahim. Welcome on the first day of our Congress. Welcome to all of you. I am honored to participate in the first workshop of this day. We have 4 workshops. One the first one we will talk about SLE, which is a rich field of complication of presentation of diagnosis and workup, how to diagnose, how to manage, what is the pathogenesis of lupus. This workshop include pathophysiology of lupus, updated and how to monitor the activity, and where we stand now, treat to target strategy, and our experience in the management of cases in Egypt and in other country. I am honored to present Professor Carlos Salman. Carlos Salman will start about pathophysiology of lupus. Professor Carlos is a coordinator of a unit of systemic autoimmune disease and vasculitis. He is a consultant on UPF in Bamboo Fabra University, Barcelona. He is a member of systemic autoimmune disease in the Spanish Society of Rheumatology. He has a lot of publication in the field of autoimmune disease and lupus. Welcome to you, Dr. Carlos.
So hello to everyone. First thing, I want to say thank you to the organization for the invitation. I'm very proud to be here. Yes, my name is Tarek Salman because my father is from Jordan. Nus Spani, Nus Ordoni. I will speak in English, but we can speak some Arabic later if you want. I will try. I'm going to speak about pathophysiology, and this is a kind of challenge for me, because I'm clinician. So I'm going to give my point of view from the clinician way, okay? And I think understanding pathophysiology in SLE is so important because we can understand how works the treatments, okay, in the disease. I can speak a little about me. Yes, I make the monographic consultation of lupus in my hospital. We care about more than 400 patients with SLE, and from 10 years ago, I also make a nephrologist consultation together at the same time with a nephrologist. And this is what it was very revolutionary way in Spain when we started. Many hospitals are following our way of work, I made my doctoral thesis in SLE in 2016. I'm now directing 4 theses in SLE. And we have like different lines of research. Now, one of the more important are imaging techniques in osteomuscular disease as rheumatologists, And we are like making new techniques. For example, we are using share wave fibroscan. This is famous for fibrosis in the liver for fibrosis patients. And we're using it in a revolutionary way in the world for the synovitis. We can speak later if you want about this. And yes, I'm co-author of the Spanish guidelines and registries, and the principal investigator of anifrolumab registry in Spain. If you want, I can show data later. But we go through the pathophysiology. This is hard, okay, for starting. Thank you to be here because it's going to be amazing. Conflict of interest. Okay, for sure. Conflict of interest. And we are going through the etiopathogenesis and pathophysiology in general. I'm going to explain it as we have been explaining it until anifrolumab came, okay? When a new treatment is coming, more research is done. So there are new things and amazing new things in the pathophysiology of SLE that we are going to tell today. After, we will center ourselves in the role of the interferon type and how it's working in SLE. In a general way, we can say that, we have like a genetic background for sure in SLE. Environmental factors are very important. The most one is the ultraviolet sun exposure. Hormonal state, it's also very important. We have like prevalence 9 opposite to 1 in female patients, because the sexual hormones, the female sexual hormones, are very important in the pathophysiology of SLE, and also epigenetic, infections, emotional stress, physical stress, tobacco. They make pro-inflammatory state in our patient of SLE, and the pro-inflammatory cytokines start with these factors, and after we will see that antibodies are created, immunocomplexes are created, and they deposit in the different organs, and they make the damage. SLE is a multisystemic illness, can affect nearly to any organ in the body. This is in Spanish, but I will translate everything. I didn't want to change it because this is the diagram I'm telling for maybe 15 years in SLE, okay, and also in the university. And I will tell one step one by one, okay? Everything starts because there is a lack of clearance of the immunoapoptotic cells. And this is a problem. And this is the main problem of the pathophysiology. So, as you can see, there is a lack of clearance of this immune nuclear and material of the immune cells, and this makes the B cells to be activated. This is the first step. B cells are activated and they make antibodies. There is also a hypocomplementemia. Hypocomplementemia. Complement is very important also for the clearance of the apoptosis, but we have deficit in SLE. So once the B cell is activated, it's going to activate the dendritic cell, plasmacytoid dendritic cells, okay? And this is the part of the pathophysiology where more interferon alpha is a subunit on interferon type 1. We will see later this. And this is the part of the pathophysiology where more amount of interferon alpha is secreted. It goes through two receptors, Toll-like receptor 9 and 7. This interferon alpha allowed to the B lymphocyte to be stimulated again and to make the co-stimulation between T and B cell. In this point is the point where more amount of antibodies, pro-inflammatory cytokines, and immunoglobulins are created by the B cell, okay? And one of these is BAF-BLyS. We can see also interferon alpha and CD4. Okay, there is also a problem in the netosis. Netosis is the programmed death from neutrophils. And look, this is going to be important in the future, okay? Because if we don't have apoptosis in the neutrophils, more interferon alpha is created and more tolerance in the dendritic cells. Okay, and this is how we were speaking about pathophysiology until now. Now I will tell you how each treatment is working in each part of this diagram, okay? As you can see, now we can start about interferon. Before anifrolumab, there were two options, the clinical trial that failed. There was safalimumab and rontalimumab, and the problem was that they were inhibiting the interferon alpha. This is a subunit of interferon type 1, and they failed it, okay? I did not the clinical essays. Before of this, we have a really good treatment in SLE. It calls rituximab. I know you have here rituximab for many years, okay? I know it. But there were like other options, like cytotoxic options like ofanutumab and obinutuzumab. Obinutuzumab is now coming also in Spain. I will speak a little later. But the problem with rituximab is that it's not selective. It comes from the chemotherapy, and it's a cytotoxic, so it kills the whole B lymphocyte. So this is good for the effectiveness, and it's really fast also. But here's come the problems of the infections, because it's a cytotoxic, okay? After we had more selective treatments avoiding B lymphocyte activity, from 11 years we have belimumab in Spain. It's a really good treatment and it's very selective. But the problem with belimumab is that as is selective and has no infection because it goes against BAF-BLIS system, is the time to start working. It's very selective, very effective in the follow-up, but the problem to start working, you need 4 months or 6 months. And this is the good things that are very safe, but it triggers a lot to start working. Between the co-stimulation between B cell and T cell, we have tried Rigerimod and Abatacept, and it's not working. And for the B cells, sorry, I make the clinical essays of Atacicept and Tabalumab, and they failed. And look, I think they were good treatments, but the problem in that epoch, before 11 years, we have no like scores to evaluate SLE. You know, SRI, we will speak later about SRI, is a scale who came with Belimumab. So we have no the way to evaluate how was working the treatments. Indeed, the clinical essays from Rituximab, Luna, and Explorer failed because we didn't know how to measure SLE, okay? Avoiding some interleukins as 6 interleukin, you know, tocilizumab for rheumatoid arthritis. We've tried this in SLE. I remember the series of Shirota and collaborators, and they were good for the skin and also for the joint, but they had severe problems of infection and neutropenia. You know, tocilizumab in rheumatoid arthritis, we have neutropenia. So imagine an SLE. It was the problem. So it came not to be a treatment for, no indication for SLE. After, we were making essays with JAK-STAT system, and you will see, it seems they work a little the same as anifrolumab. But unfortunately, I don't know why, the phase 3 study came out with baricitinib, okay? And not biological therapy, but just DMARD, anticalcineurin, and this is really effective. We have now voclosporin. So imagine, for all these clinical trials, we only have these 4 treatments now in Spain. And now in Egypt, you have anifrolumab and rituximab. I know there is no belimumab. In Spain, we have already anifrolumab, rituximab, obinutuzumab is coming because the phase 3 study of Regency is good, it achieved the endpoints. And voclosporin, already we are using voclosporin for the lupus nephritis. And what is new? What is new? The new is that we are avoiding the effect of the interferon type 1 with anifrolumab in a very fast way. And the new is that we discovered that we have interferon type 1 not only by hematopoietic synthesis, okay? We have in the own tissues interferon type 1. And this is revolutionary. This is the new thing in the pathophysiology. I will show this in the next screens. We are going to speak a little before about what is interferon. It's a peptide, it's a pro-inflammatory cytokine synthesized by innate immune system, and it has very, very important functions in the immune system as antiviral, antiproliferative, and anti-tumor. There are different families of interferon, type 1, type 2, and type 3. And we are going to speak here about how it's working, okay? Anifrolumab goes against the one receptor of the type 1 interferon, goes here. It's a little same as anti-JAK therapy, okay? So with the binding with the one unit of the receptor of the type 1 interferon, binding him, avoid the JAK-STAT system, and avoiding this, you can stop the methylation of the DNA and the creation of pro-inflammatory genes. But if you see this, don't you remember this to the JAK-STAT therapy? It's nearly the same, okay? It's nearly the same. Sorry. Very important also are the subunits of the interferon. We are going to center ourselves in type 1 interferon. It has 17 subunits. And you need to remember them, okay, because they are going to be very important in each tissue, as you will see in the next slides. Interferon alpha is very important in the hematopoietic system, okay, to activate the plasmacytoid cells. And it's going to be very important in the kidney and also in the central nervous system. Interferon beta is going to be very important in the joint. Interferon kappa is going to be very important in the keratinocytes, as you will see. And we have also interferon epsilon and omega. Yes, I know there are many subunits, but we need to be related with them because we are going to speak so much about these units in the next years, as you will see. So interferon type 1 is working also in the innate and the adaptive immune system as well. What makes activation of myeloid dendritic cells before plasmacytoid dendritic cells, increasing the netosis, more netosis, more interferon alpha. You will see there is a kind of loop in the pathophysiology of SLE, affects to the phagocytosis of the monocytes and macrophages, and increase the cytokine pro-inflammatory production, okay? In the adaptative, they reduce interleukin-2 production, and if you think, okay, but this interleukin-2 is pro-inflammatory, yes, but it's regulatory also. It's speaking about tolerance, okay? Makes polarization towards helper lymphocytes, 17, for example. We have less cytotoxic CD8 lymphocytes and more CD4, for sure. So interferon type 1 goes to a pro-inflammatory state always in our patient. And at the end, make expansion of autoreactive B cell and production of antibodies. And there is only interferon type 1 in SLE? No. Look, we have interferon type 1 in healthy subjects. We have interferon less than in the illness, okay? We have a lot of interferon 1 in rheumatoid arthritis, for sure in SLE, dermatomyositis, polymyositis, and Sjögren's syndrome. And indeed, we are making essays in clinical essays and trials in this type of conditions, okay? And I think, I'm sure, because I'm using in off-label way, okay, I need to say this, for example, dermatomyositis patients in my hospital, and it's working. I think anifrolumab is going to work for everything. Systemic sclerosis, polymyositis, dermatomyositis. You will see, it's a really great molecule. This is nearly the same. I'm going to be very, very fast in here. We have like external condition, virus cells, ultraviolet light, and they make the pro-inflammatory state to be a start. We have like rest of nuclear antigens, and that actives to the plasmacytoid cells. Plasmacytoid cells make secretate type 1 interferon, and everything starts, okay? They make the B cell to produce BAF, BLIS, and TNF alpha, alpha TNF, and the co-stimulation between B cell anti-TEMs, antibodies, you know, SM, anti-Rho, anti-DNA, anti-RNP, antibodies, immunoglobulins, they deposit in the tissues and they make the damage. Okay, this is the same as the first in a very fast way. And there is a kind of loop, and this is the problem in SLE, okay? I'm going to read this exactly to have a better idea of how it's working interferon type 1. Nuclear extracellular material is potent stimulus for antibody production for interferon type 1 response, as we said before. Stimulation with interferon type 1 increased expression of toll-like receptor 7 on B cells, promotes BAF production, and strongly promotes differentiation of B cells into plasmablasts. We have told this also. Immunocomplexes may also stimulate the interferon pathway. So more B cell activation, more interferon, more B cell activation. And there is a kind of loop, okay? The interferon pathway causes plasma cells to be activated regardless of antigenic specificity because we lost the tolerance in SLE, and further contributing to the inflammatory feedback loop in SLE, as I have been told before. And in the chronic way, there is more loop and more interferon because when immunocomplexes are created, more plasmacytoid dendritic cells are activated, and there is more interferon type 1. So the loop is always working in SLE if we don't stop it. What makes interferon type 1? Modulates both innate and adaptive immune response, developing of high affinity antigen-specific responses via interaction with plasmacytoid dendritic cells, myeloid dendritic cells, monocytes, natural killers, T and B cells, promotes the maturation of the dendritic cells, increasing cytolytic activities of natural killers and cytotoxic T cells, contributing to the activation of the B cell, okay, and the production of the immunoglobulins. And this is nearly the same. It works in the innate immune system, activating myeloid and plasmacytoid dendritic cells, and in the adaptive immune system, and activate the B cell activation and antibodies, formation of immunocomplexes, and going to the different tissues. But you see, if we don't stop this, it's more B cell activation, more antibodies, and more interferon alpha. We need to stop this loop, okay? For sure, there are many studies, basic studies, measuring the amount of pro-inflammatory cytokines after treatment with anifrolumab. And for sure, is with after anifrolumab, we have less alpha TNF, less interleukin 6, and less interleukin 8. This is very easy to understand. And this is really, really interesting. Look, we have like in preclinical stages in SLE, we can see that patients in preclinical study, they have already interferon type 1 before SLE starts, okay? And interferon type 1 contributes to create an antibodies. How we measure interferon type 1? We can measure interferon regulatory factor. We have 5 and 7. So interferon regulatory factor goes directly to interferon alpha, makes interferon alpha, and it allows to create the antibodies. Interferon regulatory factor 5 action to anti-Rho, and you know anti-Rho antibody is very important in the pathophysiology of SLE, not only DNA, okay? I have published recently, 1 week ago, the phenotypes associated to anti-Rho in SLE. You can read in PubMed now. Really interesting because we saw it in the Sjögren's system, Sjögren's disease and lupus overlap, lupus anti-Rho alone, and lupus anti-DNA, and we compare in our cohort of patients. And interferon regulatory factor 7 activate anti-SM, and it has been measured in African patients. And it's really clear that most patients with established SLE present a sustained state of elevation of the interferon pathway associated with disease activity and different clinical presentation in all the domains, in renal, hematologic, central nervous system, skin, as you will see now. And this is the new thing. And they realized just one year ago. It was Antoni Sarras. Antoni Sarras is working in the UK. I was having a meeting the other day with him. I invited him to the Spanish Congress of Autoimmunity like 1 month ago. And Antoni Sarras was making his postdoctoral studies, his thesis, on this. Look, how they realized that there is not only hematopoietic interferon type 1. How they realized? They were taking skins of SLE patients and they measure the plasmacytoid cells and also the interferon type 1. And they realized that there were very high amount in the skin. But when they measure it in the blood, there was not. So we have our own interferon type 1 in the tissues. And why? And this is why anifrolumab is working in every tissues. And why is because anifrolumab is working very fast? Because we have own secretion in the tissues. For example, in the skin, you are going to see that interferon type 1 is produced by keratinocytes, in the kidney by the tubular cells, in the joint by the synovial stromal cells, and in the brain by microglia cells, astrocytes, and it makes endothelial cells to be function by their own. You will see now in a few. So they compare these plasmacytoid dendritic cells with relatives of SLE patients, and they call it patient at risk, you know, because they were ANA positive and they were relatives of SLE patients. They measure in SLE patients and also in healthy controls. And it is supposed to have more plasmacytoid dendritic cells in SLE patients, but was not. There was less, and even than in healthy controls. So they were thinking, wow, maybe we have like interferon type 1, non-hematopoietic type interferon 1, okay? Produced in their own tissues. And yes, it's produced in their own tissues. As I have said, in the skin, it's very important, the production by the interferon kappa. So I told you, you need to remember the switch units. In the kidney, we have a lot of interferon alpha. In the brain, we have interferon alpha and beta. In the synovium, interferon beta. And in the lymphoma tissues, they work directly the plasmablast because this is hematopoietic, okay? We are going to see each one by one. And this is really, really interesting and amazing, you know, because it's really new. You know, in the paper of Sarras, if you need to read any paper about this, go to Go to this paper, that one, down, okay? Oh, it's not read, you cannot read, I can give you the the reference later, okay? And they created in the paper a model because they think everything is starting in the tissues, not also both together, okay? Hematopoietic, but also in the tissues. So they created this model. They think the ultraviolet sun exposure activates the interferon kappa, and the interferon kappa activates the plasmacytoid dendritic cells. But the important thing is that they go to inert dendritic cells. So we can, if we measure them in the blood, we are not going to find them sometimes in states of activity in SLE, mainly in the skin affectation. For example, if we are going to measure them in a thrombocytopenia, for sure we are going to have them in the blood. But for example, in the joint or in the skin, we see there is no amount of plasmacytoid cells when we measure them because they go to inert, okay? And then is the rest is the same I told you before. Dendritic plasmacytoid dendritic cells activates the B cell, antibody production, DNA, RNP, anti-Rho, and they make immunocomplexes, and they go to the tissues. And this is the same what we told. But the main thing here is that plasmacytoid cells go to inert, okay? So we have interferon type 1 in the tissues. And why is this is working in every part of the body, anifrolumab, okay? It works in the skin, in the joints, in the central nervous system, cardiovascular, and liver. And we can measure it. The good way to measure is measure the interferon pathway, the interferon signature, with the interferon stimulated genes, okay? For example, in skin, it's going to be interferon beta, and there is not only interferon type 1, also interferon type 3, and it makes, the production of interferon type 1 and activates the immune system and develop the mucocutaneous manifestations. This is what we told before, okay? How did they realize? They were making biopsies, skin biopsies to normal patients and patient at risk, and a positive without SLE, and SLE patients. And they were watching that interferon was in the skin, not in the blood, okay? What happened in the synovium? There is interferon type 1. At what subunit of interferon I told it was? Do you remember? No? Beta, okay? You need to remember. Okay, interferon beta is in the synovium, and this is really interesting to me because I'm researching in imaging studies in SLE. You know why it's not erosive, the disease, the joint disease in SLE? Because of this. Because interferon beta inhibits osteoclastogenesis, okay? And there is no erosion because there is no erosions in the X-ray, okay? We are the second group in the world watching erosions in the MRI. You can read my papers. Okay, interferon beta also make an upregulation of transforming growing factor beta, and this is very, very fibrotic, interleukin 10 and interleukin 1. This is the way of working. In the synovium, central nervous system, we have both interferon alpha and interferon beta. And how they knew how it was working type 1 interferon over there? Because it's nearly the same, the pathophysiology of Aicardi-Gutierrez. Aicardi-Gutierrez is an interferonopathy, okay, regulated by TREX and some HD genes, and it's a little the same. They are in this disease, there are a lot of amount of production of interferon type 1, and it makes inflammation and encephalitis, and it's a little the same of the neuropsychiatric SLE. I will show you. We have three mechanisms in the central nervous system, okay? One is, sorry about this. We have three mechanisms. Interferon type 1 is produced by microglia cells in here, okay? Also by astrocytes, and there is interferon type 1 makes endothelial activation and the damage in the vessels, in the more small vessels in the neuropsychiatric SLE. And this is why we have like problems in the microcirculatory. Okay, so it's going to work in the central nervous system for sure. I know in the technical sheet we cannot put it in these patients, okay? But if you want, I can tell you something off-label later, okay? I'm sure that it's going to work in central nervous system as rituximab, for example. Also in the vessels, I told you, interferon type 1 induce endothelial damage. So avoiding this, we will have no vasculitis. So it's going to work in vasculitis, and also it's going to improve our arteriosclerotic profile in our body, and working also in the cardiovascular disease. In the kidney, we have interferon alpha, and it's secreted by the cells of the tubular cells, not in the glomerulo. You cannot find interferon in the glomerulo, okay? And what is making this interferon type 1 in the kidney? It makes proliferative glomerulonephritis and fibrosis. Indeed, what it makes interferon alpha in the glomerulo, it makes endothelial dysfunction, cell death, podocyte loss, and induction of fibrosis. And we can find like signs of the interferon footprints in the histological, in the biopsy, okay? We can find aggregates of branching membranous tubules within the cisterna of the endoplasmic reticulum that they are typically located in endothelial cells. This is the sign of the interferon in the biopsy. Hematological is very easy because it's not non-hematopoietical, it's hematopoietical. So plasmablasts activates directly to the B cells and they make antibodies, and we have hemolytic anemia, thrombocytopenia, antibody neutropenia. This is very easy to understand, okay? I will not extend myself in here. So how is working anifrolumab? Anifrolumab binds to the type 1 interferon receptor and blocks receptor dimerization and induces receptor internalization. So if you see, but this binding, we stop the JAK-STAT system, we avoid the methylation of the DNA and the expression of the interferon-regulated genes. This is how really started today, if you remember. And we can measure this internalization very fast, in hours after anifrolumab, as you can see in the diagram here. So I will finish saying that anifrolumab makes a lot of actions in the immune system because it reduces the apoptosis, decreases the endothelial activation. We saw each point of this, okay, before. Reduction of pro-inflammatory cytokines and chemokines, reduce chemokines associated with B cell, T cell, and another immune cell recruitment, reduction in the net formation, normalization of lymphopenia, neutropenia, and thrombocytopenia, suppression of antigen presentation, normalization of T cell activation, decrease monocyte macrophage recruitment and activation, and at the end, and this is the most important, reduction in activation and survival of B cells and decrease B cell differentiation into plasma cells. And that's all. Many thanks.
Thanks, Professor Dr. Carlos, for this difficult and condensed presentation. First of all, I would like to thank AstraZeneca for sharing of this highly scientific session. And let's to continue. I am honored to present our of the eminent and godfathers, Professor, both Professor Muhammad Salah and Professor Kamel Heshmat. We consider them as one of the referral professor and our leaders in Egypt in one of the eminent university, Ain Shams University and Cairo University. Professor Muhammad Salah will talk about where we stand now. احنا مش عارفين هو هيقول ايه في المحاضرة where we stand now فعلا.
Bismillah ar-Rahman ar-Rahim. Welcome all of you. Welcome Professor Carlos Salman for visiting Cairo. This is the second time to visit Cairo. He told me that he came 20 years ago when he was a child. Welcome in Cairo, Professor. After this nice introduction by Professor Carlos about this physiology of systemic lupus, I ask you to present where we stand now in management of systemic lupus. This is now an important, very important question because we have very much advances now in the management of systemic lupus, as you know. These are my disclosures, evidence-based references, if you want to follow. This is our agenda. This is our agenda. As I remind you, this is May is Lupus Awareness Month. Remember, of you, this is to spread the awareness of lupus for all populations. Is yes. As all you know, that the systemic lupus is a chronic multi-system autoimmune disease with extremely variable clinical manifestations, unpredictable course and flares, as all you know. It may affect any system in the body with any degree of severity, depending on the genetic and ethnic background, as all you know also. Management of systemic lupus, you know the natural course of the disease. We have a preclinical phase where we have antibodies for several years, and then development of the clinical course of the disease. This clinical course is characterized by frequent flares activity, accompanied by more and more inflammation and accrual of damage, as you see here. If you follow this conventional approach, you have more frequent flares, more active inflammation, and actually more accrual of organ damage. If you follow treat to target strategy to achieve remission or low disease activity, this means less active disease, less flares, less inflammation, and accordingly it will be less damage accrual, as you see here. So this is the impact of treat to target strategy on the natural course of the disease. So minimizing disease activity, this is our aim through achieving remission or low disease activity. This means slowing and the prevention of organ damage, because we have less flares, less inflammation, and less organ damage. If it is lupus nephritis, less progression to end-stage kidney disease. This is, I think, will be defined by Professor Dr. Kamel about the disease modification definition. Treat to target. Before, you are always asking which target to achieve. We have no definite target in systemic lupus like rheumatoid arthritis, for example. But now the situation was changing. We have now well-defined, validated targets. We have target of remission. We have now a defined remission, validated target. Remission, according to the DORA's definition into 2021, is SLEDAI equals 0, physician global assessment less than 0.5, steroids 5 milligrams or less, and stable doses of antimalarials, immunosuppressives, and approved biologics. Low disease activity, also defined and validated. SLEDAI equals 4 or less. Physician global assessment is 1 or less. Prednisolone is 7.5 milligrams or less, although this is changed in the new recommendations of whether to become 5 milligrams on. And with well-tolerated standard maintenance doses of immunosuppressives and approved biologics. Again, a very important point. This is the use of steroids. You know that steroids for many years was a cornerstone therapy of systemic lupus erythematosus, and big doses were usually used in management of systemic lupus. And now we realize that this is one of the major factors in the accrual of damage in systemic lupus. This is the organ damage outcomes of patients with systemic lupus by corticosteroid exposure. This is a long-term follow-up study in Toronto Lupus Cohort to start with no baseline organ damage, patients steroid naive, and patients on steroids, follow up for many years. As you see, here's a difference between steroid naive and steroid exposed patients over 3 years, over 5 years, over 8 years, and you see there is a great difference, significant difference between damage accrual between patients with steroid naive and steroid exposed over years. So steroids is one of the main factors in damage accrual in systemic lupus. As all you know that ELAR issued new recommendations for management of systemic lupus. 2 years ago, that presented in the in Milano the year before the last one. And there is a shift in paradigm of systemic lupus management presented in these guidelines. These guidelines will be discussed in details by Professor Dr. Dalia Fay, so I have only 2 slides to have the main ideas in the paradigm shift of these recommendations. Treatment of non-renal systemic lupus, we have now target, as I explained, target of remission and low disease activity. All patients should receive hydroxychloroquine unless contraindicated, and glucocorticoids, if needed. This means it should not be given for every patient in high dose like before. It is, you can use it as a bridge therapy like what happens in rheumatoid arthritis. Glucocorticoids, if needed, short-term use to control active disease, taper to 5 milligrams or less as quickly as possible, and discontinue if possible. This is very important trend or paradigm shift in the management of systemic lupus. The second point is early introduction of immunosuppressives and or approved biologics early in the disease, even the mild disease, early to achieve our target of remission or low disease activity, or to help with taper steroid treatment, as you see. This is the main paradigm shift in management of systemic lupus presented in these recommendations. Again, the same for lupus nephritis. We have treat to target strategy. We have target now a 3 months reduction of 25% of protein creatinine ratio, less than 50% after 6 months, and to be less than 0.5 or 0.7 after 12 months. We have a target now to achieve. We have timetable. Again, hydroxychloroquine for all patients. Steroids will be given for all patients. Pulse maybe at a lower dose than before, and oral maintenance at a lower dose than before, from 0.3 to 0.5 milligrams per kg, to taper to 5 milligrams as quickly as possible. And we will use immunosuppressives, immunomodulators like MMF or low-dose cyclophosphamide, but here, combinations therapy should be considered. This is another paradigm shift. Combination like MMF and belimumab, or MMF plus calcium inhibitors like voclosporin or tacrolimus. This is important, another important paradigm shift in management of lupus nephritis. And this also was confirmed later on by ACR guidelines for management of lupus nephritis. So the main key points from EULAR recommendations: early diagnosis is very important. Treat to target of remission or low disease activity with less flares, less inflammation, less organ damage. Hydroxychloroquine for all patients, and steroid should be minimized as initial dose and maintenance dose, as we mentioned. And the last point is immunosuppressives and approved biologics to be considered to control this activity early in the course of the disease, to avoid flares and activity and more accrual of damage, and to facilitate glucocorticoid tapering and withdrawal. This is the ACR again, ACR guidelines presented in the last ACR conventions conference in Washington, D.C. last year. Again, it's very similar principles as EULAR recommendations. In proven lupus nephritis, class 4, class 3 or 4 with or without class 5, or class 5, hydroxychloroquine and renin-angiotensin aldosterone system inhibitors for all patients unless contraindicated. The steroids, pulse steroid may be at a lower dose, and then maintenance, 0.5 milligrams per kg. Maximum dose is 40 milligrams to be withdrawn to 5 milligrams daily over 6 months. Mainly the same principle, less steroid use, either in the pulse or in the maintenance therapy. And here, there is a clear indication that triple therapy is the first choice. Triple therapy, for example, in class 3 and 4, MMF steroids, MMF plus belimumab or calcineurin inhibitors. And in cases of pure class 5, we may prefer first line MMF plus calcineurin inhibitor. So they advise triple therapy as first line therapy, and only dual therapy if triple therapy is not available or not tolerated. This is an important paradigm shift also to give more aggressive treatment early in the course of the disease, aiming at disease modification, prevention of flares, prevention of accrual of damage of the kidney, prevention of development of end-stage kidney disease. As you see, drug therapy for lupus over many years. Most of the standard therapies used in systemic lupus, glucocorticoids, antimalarials, azathioprine, cyclophosphamide, used for many years since the 1950s and 1960s. And over more than 50 years, there's no single new drug for systemic lupus approved. The first approved after many years in 2011, belimumab is the first biologic to be approved after 50 years of no new drugs approval for systemic lupus. In 2011, belimumab was approved for treatment of severe or moderate systemic lupus, added to standard of care, and this was followed by newer drugs and anifrolumab, and then voclosporin later on for systemic lupus in 21 years to be approved to be used in systemic lupus. And as you see, we stayed a very long time, more than 50 years, without any new developments in treatment of systemic lupus, with no single drug approval over all of this time. This is a pathogenesis which was beautifully explained by Professor Dr. Tarek. The main target, as you see here, these are the possible targets for systemic lupus management. It may be B cell, plasma cells, B T cell co-stimulation, interferons, as Professor Tarek explains, the major role of interferon alpha is the pathophysiology of systemic lupus, and JAK system also is maybe a target, and other cytokines. Currently, we have these approved biologics for treatment of systemic lupus. Belimumab and anifrolumab are approved for systemic lupus treatment. Belimumab approved in 2011 for treatment of lupus, and for nephritis in 2020. And anifrolumab approved very recently in 2021 for treatment of severe or moderate lupus. Rituximab is available but not approved. It's used off-label indication based on personal experience and observational studies in refractory cases. In Egypt, we have, fortunately, rituximab since a long time, and anifrolumab recently introduced in last year. We haven't belimumab in Egypt. Belimumab is listed as the first biologic approved for treatment of systemic lupus. It selectively binds to lymphocyte stimulated protein, BLES. Was approved in March 2011 by FDA for treatment of moderate or severe lupus. And on 2020, it was approved for treatment of lupus nephritis after publication of phase 3 clinical trial belimumab in lupus nephritis on 448 patients with lupus nephritis, compared to placebo plus standard of care, continued for two years, and the results of belimumab showed improvement of 2-year renal responses at the end of the study. This is the BLESS lupus nephritis, phase 3 belimumab in lupus nephritis. As you see here, one arm belimumab 10 milligrams per kg, and the other one is placebo, added to the standard of care, either MMF or cyclophosphamide, and continued for 2 years. And they found that the group of belimumab achieved better renal response than that of placebo, achieving the primary endpoint of primary efficacy renal response at 2 years. And for this, it is what has proved for treatment of lupus nephritis, as I told you, in 2020, December 2020. The other new oral drug, voclosporin, it is a novel calcineurin inhibitor, works by blocking interleukin 2 expression, T cell stimulation, and stabilizing podocyte of the kidney. So it has a very rapid effect in reducing proteinuria, mainly for this reason. Also, this was tried in Aurora trial, placebo-controlled trial, against added to standard of care therapy over 1 year, and it showed also efficacy. And it was approved in 2021 as a first oral treatment for specifically developed for lupus nephritis. This is the Aurora trial. As you see here, one arm voclosporin plus the standard of care, the other arm placebo plus standard of care for 1 year, 52 weeks. It also achieved the primary endpoint of complete renal response. As you see here, the primary endpoints of these two trials, this is for belimumab trial, BLISS lupus nephritis, belimumab lupus nephritis trial. This is the placebo arm, achieved 32%, and belimumab arm achieved 43% of primary efficacy renal response at the end of 2 years. The other one for Aurora trial of voclosporin, as you see, after 52 weeks, after 1 year, it achieved complete renal response. This is a placebo in green, achieved the 22% complete renal response, while voclosporin group achieved 40% response in the group. When to use belimumab or voclosporin, as you see, if we have GFR less than 45, we prefer to use belimumab. If level of proteinuria is less than 3 grams, if there is concern for safety or difficulty to adhere to oral treatment, or there are extrarenal disease, you may prefer in this situation to use belimumab in combination with MMF. But if you have estimated GFR more than 45, patient have high levels of proteinuria, more than 3 grams, or able to adhere to combination of oral therapy, we use in these situations voclosporin. We haven't bought the drugs in Egypt, unfortunately, but we have here tacrolimus as a calcineurin inhibitors may be an alternative. Then anifrolumab, as all you know, it is a human monoclonal antibody, binds to interferon alpha receptor, as Professor Tar explained, blocks the activity of type 1 interferon, approved by FDA in August 2021 for adult patients, moderate or severe lupus, who are receiving standard of care treatment based on 2 trials, TULIP-1, TULIP-2, mainly TULIP-2 results, because achieved the primary endpoints. It's given intravenously or by infusion over half an hour every month, 300 milligrams. This is a TULIP-1, 2 trial published in New England Journal of Medicine, and show the arm of anifrolumab, 300 milligrams intravenously every 4 weeks, plus against placebo, added to standard, both of them with a standard of care for 52 weeks, 1 year. The primary endpoint is BICLA response. BICLA means British Islet Composite Lupus Assessment. As you see here, the primary endpoint, BICLA, was achieved at the end of the trial, 47.8% for anifrolumab group, compared to 31.5% for placebo group after 52 weeks. Again, this is a percentage of DORIS remission rate by treatment group. This is a pooled analysis for TULIP-1 and TULIP-2. As you see here, remission rates increase over time to reach 15% by the end of the trial at 52 weeks, to reach 15% against 7.6% in the placebo group. As you see, a big much difference between 2 groups to achieve remission in patients with systemic lupus. Again, this is the efficacy across organ domains scores over 52 weeks, the SLEDAI 2K score in different organs. As you see now, more patients responded in the mucocutaneous, in the musculoskeletal, in the immunological, vascular, hematological domains with anifrolumab than with placebo in different organ affection, as you see here. With the exception of renal, CNS were not included in the study from but just few patients with renal less than 2 grams was present, showed some improvement, but this is not included mainly as a case of renal affection. This is the maintenance of this effect over 4 years. After TULIP-1 and the TULIP-2, there was a long-term extension trial to assess more efficacy and safety of the drug over long time. After 4 years, as you see here, mean SLEDAI 2K score, as you see, decreased from the baseline, and this was continued over 4 years follow-up in the long extension trial, long-term extension trial. Again, this is a very important slide. This slide was presented as an important poster in the EULAR last year. It showed that one of the main aims now of management of systemic lupus is a reduction of steroids. As you see here, after 4 years of use of anifrolumab, Safnelo, 36 of anifrolumab patients were free of glucocorticoids, no steroids. 36 of patients, and 74% or 75% nearly were receiving glucocorticoids either 0 or less than 5 milligrams after 4 years. And only 9.9% of patients was more than 7.5 milligrams, compared to nearly 30% in the placebo group. As you see, this is a very important achievement for the drug after use for a long time. This paper was published very recently in the last issue of Annals of Rheumatic Disease, May 2025, about the role of anifrolumab in prevention of damage accrual in systemic lupus. We know that anifrolumab is effective for controlling disease activity and reducing dose of glucocorticoids. In this paper, they concluded that about 60% reduction of damage accrual in the anifrolumab group compared to placebo group by follow-up over 4 years. And they conclude that patients who received the anifrolumab significantly has less organ damage after 4 years. And this is very important also about this drug. These are some trials of new medications in the pipelines, expecting to have approvals in the first few years. The first one is obinutuzumab. Obinutuzumab in Regency trial proves efficacy in lupus nephritis. Obinutuzumab is a humanized type 2 anti-CD20 monoclonal antibody. We have it in Egypt, this drug now. It's Gazyva, similar one to rituximab. This is another generation of rituximab. It provides better renal response. In Regency trial, this is a phase 3 trial, studied 271 patients with biopsy-proven lupus nephritis, and was published very recently in February 2025 in New England Journal of Medicine. And this is the result of this. As you see here, complete renal response at 76 weeks observed. 46% for the group of the drug and 33% for the placebo, and the difference is 13%. And it is expected that this drug will be approved for treatment of lupus nephritis in the near future, maybe during this year, by October this year, 2025. Another one, deucravacitinib, this paper presented in the last ECR. Deucravacitinib is the first one in class of tyrosine kinase TYK2 inhibitors approved for treatment of plaque psoriasis. It also showed efficacy in treatment of lupus in phase 2 clinical trial by different dosing. They found that in phase 2 clinical trial, deucravacitinib 3 milligrams twice daily associated with improvement of different scores of SRI-4, BICLA, CLASI 50, and joint count 50 in patients with systemic lupus in comparison to placebo, and more validation needed in phase 3 clinical trials. Another one, dapirolizumab pegol demonstrated significant improvement in SLE activity. This paper was presented in the last ACR conversions as a breaking abstract. Dapirolizumab pegol is a pegylated antigen binding Fab fragment lacking an FEC domain, inhibits CD40 ligand. By binding to CD40 ligand with broad immunomodulatory effect, including reducing B cell activity, T cell activity, and dysregulating also interferon pathways. In phase 3 trial, it achieved the primary endpoint of BICLA, and they gave a conclusion that treatment with dapirolizumab, the novel CD40 ligand inhibitor, resulted in improvement in disease activity and the corticosteroid tapering in patients with systemic lupus. Again, telitacicept, this is another drug, human recombinant fusion protein targeting B cell lymphocytes stimulation like belimumab, but again, targeting proliferation-inducing ligand, APRIL, so it has a dual mechanism in suppressing B cell stimulation. In phase 2 clinical trial, it achieved the primary endpoint of SRI-4, and they conclude that all different concentrations of telitacicept achieved the primary endpoint significantly in comparison to placebo, and we're awaiting more validation in phase 3 clinical trial. This drug is already approved in China for treatment of systemic lupus erythematosus. The last new approach is the CAR T cell. This many papers presented in the last ELR and the ACR about CAR T cell used in the management of different autoimmune diseases. CAR T cells are a gene-modified cell therapy in which viral vector, as you see here, is used to insert the receptor gene into autologous T cell, which allow T cell to recognize cell antigen like CD19 and elimination of the target cells, CD19 B cells, with deep depletion of these cells. There are some risks for this procedure, like cytokine release syndrome, immune effector cell neurotoxicity syndrome, the very high cost and the technical difficulties. As I told you, several presentations, several papers presented in the last ULR and ACR about these T cells, and the important publication in the New England Journal of Medicine about series of patients treated with these CAR T cells, including systemic lupus, inflammatory polymyositis, and systemic sclerosis. And the idea of this cell is to have a deep depletion of B cells, to have a resetting of the immune system, and have long-term drug-free remission. These cells are targeting, for example, CD19 B cells with complete depletion in the blood and tissues, and resetting the immune system and making the patient in the drug-free remission for a long time. They showed efficacy in these 3 diseases, but we need further controlled clinical trials. And as I told you, there's a concern for safety and manufacturing difficulty. Let us conclude, as I told, that SLE is a chronic heterogeneous autoimmune disease with a wide spectrum of clinical symptoms that can lead to irreversible organ damage. Defining treatment targets for systemic lupus is important. Target of remission and low disease activity. And again, glucocorticoids use are challenges in management of systemic lupus. In ELR 2023 recommendations, steroid use should be minimized, and immunosuppressives and or biologics should be considered to control and control disease activity and facilitate glucocorticoid tapering and withdrawal. Since 1950, no new treatments being approved for decades, as I told you. And the first one was approved after a long time of abstinence. It was belimumab in 2011 for treatment of systemic lupus. This was followed by uh, belimumab for lupus nephritis in 2020, December 2020, approved for lupus nephritis based on trials which I told you. And then in January 2021, voclosporin was approved as a first oral treatment for treatment of lupus nephritis. And lastly, in August 2021, FDA approved the anifrolumab or Safnelo for adult patients with moderate to severe lupus, patient receiving standard of care. And as you see, there are several ongoing trials for novel treatment for systemic lupus, waiting for more and more approvals in the next few years, with more revolution in the management of systemic lupus erythematosus. And thank you very much for your attention.
Thank you, Professor Muhammad Salah, for this updated lecture. Professor Muhammad Salah is our godfather in rheumatology department at Ain Shams University. We owe him a lot in learning and teaching us a lot about rheumatology before the internet and everything that was available. I would like also to thank AstraZeneca for sponsoring this important workshop about mastering the complex in lupus, a difficult heterogeneous disease, coinciding with the International Day of Lupus on the 10th of May. After knowing the pathogenesis of the disease, how we treat, it is very important to monitor the treatment you are giving and how you will change your treatment, either escalated or tapering the treatment. And this will be according to disease activity indices, damage indices. This is a very difficult task that was handled to Professor Dr. Kamel Hashmant, and he is going to tell us about how to monitor our patient with systemic lupus to better tailor our treatment and to better reach our target. Professor Kamel. Professor Kamel Hashmant is an emerite professor of rheumatology, Cairo University. He is one of our referral professors as well if we have any difficult cases. So please, Professor Kamel.
بسم الله الرحمن الرحيم. كل سنة وانتم طيبين. أحب أهني عين شمس على مؤتمرهم اللي إن شاء الله ناجح جدا. عين شمس دي بيتي التاني. أنا ببقى سعيد كل سنة لما أجي أقابل إخواتي وبناتي في هذا القسم العريق، وإمبرسيف جدا الكلام اللي أنتم كتبتوه في الأجندة على تطور وحدة الروماتيزم والمناعة. ربنا يوفقكم إن شاء الله. I am going to speak. They asked. I would like to first to welcome Professor Salman for his second visit to Egypt, and I would like to thank the medical department of AstraZeneca, Dr. Omnia, for providing some of the slides that are going to be presented in this presentation. This is my conflict of interest. SLE, as it has been said several times, is a heterogeneous chronic systemic autoimmune disease of variable severity and course. Incidence ranges between 0.3 to 31 cases per 100,000 individuals per year, and has been increasing in the last decade, probably because of increased recognition. Approximately 50% of cases start as mild, but may progress in severity, so that mild, moderate, and severe cases are equally split over time. This cartoon shows that at the beginning, this is the presentation: 50% mild, 33% moderate, and 17% severe. By the lapse of time, it will be 1/3 in each division. SLE is characterized by periods of variable disease activity, which is measured by SLE disease activity indices. Frequent flares result in inflammation-driven irreversible damage, which is measured by sleek SR damage index. Tissue damage caused by autoantibodies or immune complex deposition occurs in kidneys, heart, vessels, CNS, skin, lungs, muscles, and joints, leading to significant morbidity and increased mortality. Damage is initially driven by inflammation and later with progression of disease, also by therapy. With time, comorbidities such as infection, premature atherosclerosis, and malignancies become an important part of disease burden. This cartoon has been shown by Professor Salah, which shows that frequent flares lead to increase acral damage, and if we diminish the severity of the disease and decrease the incidence of flares, the acral damage will improve. This is done by treat to target approach. What do EULAR guidelines tell us? SLE disease activity should be assessed at each clinic visit, the frequency depending on physician's discretion, with evaluation of organ damage at least annually using validated instruments. And I would like actually to congratulate the organizing committee for asking to present this tough subject, because let us face it, most of us do not actually use the activity indices and the damage index in our basic clinics. We don't do that, and it is time to do. Early SLE diagnosis, including serological assessment, regular screening for organ involvement, especially nephritis, prompt initiation of treatment aiming at remission or low disease activity. If this is not possible, and the strict adherence to treatment are essential to prevent flares and organ damage, improve prognosis, and enhance quality of life. This is the remission as presented by Professor Salah. I will not waste time in that. Just to tell you that there are different definitions of remission. There is complete remission. This is clinical. There is clinical remission on treatment, and there is clinical remission without treatment. The clinical remission with treatment is the one which is widely adopted by SLED-I 2000, 0 PGA less than 0.5, 5 milligram prednisone or less, and stable antimalarial and immunosuppressives. An alternative is the low disease activity status if we can't achieve the remission. This is described by Asia Pacific Lupus Collaboration in 2016. SLED-I 2004 or less with no major organ activity. No new SLE activity, PGA 1 or less, immunosuppressive medications, and steroids are equivalent to 7.5 milligram daily. This is actually has been changed a little bit in the most recent EULAR guidelines that actually adopted the remission as the clinical remission with treatment, as I have just mentioned. But for the low disease activity, you can see that they adopted glucocorticoid dose of 5 milligram or less. Stressing on the important matter that Professor Salah has mentioned, which is we should reduce steroids. We all see in our clinics patients that have been receiving 20 to 30 milligram prednisone for the last year or so. This should stop. These are the outcome measures that are used in lupus, in the management of lupus. Regarding the disease activity, there are global and organ specific. The global or general ones, the original one is the SLED-I. It has been modified into SLED-I 2000, which is the most popular. The second is the BILAG 2004, and these two were the actually dominating disease activity measures in the last 2 decades. PGA is the third one, Physician Global Assessment. The new ones, which I think will represent the future from now on, will be the modification of the SLED-I and the BILAG, which is the SLE disease activity score and the easy BILAG measure. There are others like SLAM, LI, and ECLAM, which are not really very popular. And for organ specific, we have got the CLASI for the skin and the complete renal response. The second group is the response indices, which is Systemic Lupus Responder Index and the BICLA, which are used in clinical trials. I will not describe them now for the sake of time, and the accrual damage, which is the sleek ACR damage index. Assessment of disease activity in SLE has a central role in clinical practice, in observational studies, and in clinical trials. In clinical practice, that's what we actually do all the time, needed to guide clinical decisions for treat-to-target management, to identify remissions and flares, to assess treatment response. In clinical trials, it is required to select appropriate candidates with active disease, to demonstrate efficacy of new drugs, to identify responders, to measure response effect size, and to assess flare rates. How do disease activity differ from organ damage in SLE? Disease activity is the presence of signs and symptoms of SLE. For example, non-scarring alopecia or rash. Flare is new or worsening symptom in one organ or more. While damage is irreversible tissue injury that lasts for 6 months or more, examples, scarring alopecia and deforming arthritis. SLED-I 2000, as I mentioned, it is the most popular. It encompasses 24 organ systems and the serologic items in 9 domains. The items are weighed with scores from 1 to 8. Disease activity assessed as present or absent. There is no continuous in the assessment of disease activity, which is a shortcoming. Items must resolve completely to obtain points for improvement. Another shortcoming of SLED-I 2000 is that it does not document partial improvement or deterioration. This is the data collection sheet for SLED-I. You can see the different systems. You can see that the CNS and the vasculitis are weighed 8 points, while the musculoskeletal and urinary costs weigh 4. Then the cutaneous 2. And actually another shortcoming is that it does not differentiate between generalized and localized. And also another shortcoming is it does not involve something like the gastrointestinal and the hemolytic anemia. These defects are actually corrected in the in the SLE DAS. These scores are totaled: mild 0 to 5, moderate 6 to 12, and severe 12 to 20. BILAG 2004 is the most sensitive ever measured in assessment of activity and improvement. The problem is that it is cumbersome. It is difficult, it takes a long time, and it needs special training, and the glossary of the definitions is not actually available in the same page when you fill the forms. So that's why it is not practical, and that's why it has been the most popular was the SLED-I 2000, and that's why they tried to modify it by the easy BILAG. BILAG 2004 is a sensitive global disease index used in patients with SLE. It is more sensitive than SLED-I 2000 in detecting active disease. The physician records symptoms if it is attributable to SLE. Disease activity is assessed as a change occurring over the past 4 weeks. BILAG 2004 can detect active disease that requires an increase in treatment. The physician scores the domain. These are the domains to the right-hand side: constitutional, mucocutaneous, CNS, musculoskeletal, cardiovascular, respiratory, abdominal, renal, ophthalmic, and hematological. If there is a new sign or symptom, it's scored as 4, and this is the computer processed into grade A, which is severe. If the physician puts 3, this is worse, translated into moderate, which is B. Same, 2, translated into C, which is mild, and improving 1 means inactive disease, which is D. So A is the worst, and the D and the E are the best. E, which is 0, never involved. BILAG 2004 is based on the concept of intent to treat. If you grade A, this means a very active disease, likely requiring immunosuppressive drugs and or corticosteroids more than 20 milligrams per day. Grade B, moderate disease activity requiring low dose corticosteroids, antimalarials, NSAIDs, or topical therapies. grade C to E, mild disease or no disease, not requiring a treatment change. Physician global assessment, this is a visual analog scale of 10 centimeter with 0, 1, 2, and 3 points. If the physician scores 0, this is none, 1 mild, 2 moderate, and 3 severe. An increase of 1 or more since the last visit is considered a flare. And this PGA is included, as I have just mentioned, in the EULAR guidelines for assessment of remission and low disease activity. Now, the most recent ones, the ones that I consider the future from now on, is the SLE-DAS and the EZ-BILAG. In 2019, Jesus and colleagues proposed and validated a new tool for disease activity assessment, the SLE disease activity score, which was derived from the SLED-I 2000. It is easy to use, takes 1 to 2 minutes to fill online form, 17-way clinical and serologic domains. It includes continuous, not just present or absent, which was the two ones which were available in the SLED-I 2000. Continuous measure for arthritis, proteinuria, thrombocytopenia, and leukopenia. It added new items like hemolytic anemia, gastrointestinal, and cardiopulmonary involvement, which were not present in the SLED-I 2000. It presents rather well-balanced weighing score. As you have seen, 8 was given to many of the CNS and the vasculitis, while lower scores were given to other systems. It gives low score to localized than generalized rash and mucocutaneous than systemic vasculitis. In addition, it identifies remission and low disease activity without the need for PGA. This is the glossary of definitions of the items that are used in SLE-DAS. And this is the SLE-DAS online calculator. You enter the data and you get the score in around 1 to 2 minutes. And these are the categories. It's either low disease activity if it is below or equal or below 2.48, mild disease activity if it is 2.48, not 2.08. Actually, I downloaded this. This is not my fault to write it wrongly. 7.64, and moderate or severe disease activity if it is more than 7.64. In addition, SLE-DAS remission is clinical items equal 0 plus prednisone 5 milligram or less. And the low disease activity is SLE-DAS equal 2.48 plus prednisone 7.5 milligram or less. What about EZ-BILAG, which is the competitor? It comes from BILAG, which is the most sensitive one. A simplified validated version of BILAG 2004. The modifications aim to make the assessment more user-friendly and efficient while maintaining its validity and reliability. Domains are represented in a single page like the SLE-DAS, not like before, to assess the majority of patients. Standard BILAG 2004 principles apply throughout. Scoring requires a clinician to circle each listed item as 0, 1, 2, 3, or 4, which is actually not present, improving, same, worse, or new. And this is translated by color coding organ domains to A, B, C, D, and E. A, highly active, B, moderate activity, C, mild, stable, D, no disease activity, and E, no current or prior disease activity, like the original BILAG 2004. This is the form. This actually part of the form, and the other part in the coming slide. You can see that the doctor puts here, assesses if the sign or symptom is not present or improving or same or worse by putting 0 or 1 or 2 or 3 or 4, and this is translated into color codes, and then the final for each system is the grading is put on the right hand side. This is mucocutaneous, musculoskeletal, cardiorespiratory, neuropsychiatric, hematology, and constitutional and renal. Should we use SLE DAS or easy by lag? This is a hot topic in those who are interested in activity measure. This was actually a subject of a symposium that was held in the late 2023, and the data were published, and the discussion was published in this very beautiful paper, which was published in January 2024. And the conclusion of this okay. The conclusion is that both indexes show significant improvement over those commonly in use. SLE DAS is better than SLE in SLID I2000, and easy by lag is better than by lag. SLE DAS is easy to use, and with the online calculator, it takes 1 to 2 minutes to capture. SLE DAS includes serology domains, which is not included in easy by lag, but does not include changes in double-stranded DNA values and complement components. The changes which is not available, but it says increased DNA or low complement, but it does not record the change from the last visit. Easy by lag demonstrates high accuracy and is the only score that allows to evaluate not only global changes, but also fluctuations in each domain. The inclusion of a brief glossary directly into the scoring page, similar to SLE DAS, allows immediate exploration among several definitions. Still, it has more complex rules and requires more time and specific training. So it is better than the original by lag 2004, but it is still not as easy as the SLE DAS. The sensitivity to change of SLE DAS is greater than SLE DI, but it has not been assessed against the easy by lag, which is derived from the most sensitive of the established instruments. This is the conclusion of the debate. Now we go to the damage index, the SLIC SCR damage index. This is the only outcome measure that we know for damage. It covers 12 organ systems: ocular, neuropsychiatric, renal, pulmonary, cardiovascular, peripheral vascular, gastrointestinal, musculoskeletal, skin, premature gonadal failure, diabetes, and malignancy. Each occurrence of organ damage is given a score from 1 to 3. Scores are additive. A higher damage index scores indicate more damage accrual. This is the data sheet for the SLIC SCR. You read the one, you read the different item, and you score accordingly. The CLASI is cutaneous lupus erythematosus disease area and the severity index. It consists of an activity and the damage score. Disease is assessed across 13 anatomical locations. Activity score 4 items and the scores ranging from 0 to 3. The damage index is 3 items and the scores ranging from 0 to 6. This is only for skin. For the joints, the joint score only using the count of swollen and tender joints. They are not using ECR or CRP like the DAS score in rheumatoid arthritis. What about the kidney? How to investigate patients with suspected lupus nephritis? Renal biopsy is indispensable. It is indicated in SLE patients with signs of kidney involvement. These include glomerular hematuria and all cellular casts, proteinuria more than 0.5 gram per 24-hour urine, or urine protein creatinine ratio of more than 500, unexplained decrease in GFR. Earlier use of biopsy is associated with improved outcome. The benefit of histological evaluation should be balanced against increased bleeding risk in those receiving anticoagulants. All patients should be tested for antiphospholipid syndrome for its prognostic implication, such as thrombotic microangiopathy. The pathological assessment still holds the 2005 International Society of Nephrology Renal Pathology Society classification, still represents the gold standard. A revision has been recently proposed. Although TMA has been reported in up to 25% of lupus nephropathy biopsies, its prognostic implication remains unclear. Tubulointerstitial lesions as interstitial fibrosis and tubular atrophy carry poor prognosis. How to monitor the progress? Spot urine protein creatinine ratio highly correlates with 24-hour urine protein collection when value is more than 1,000 milligram per 24 hours. Better to perform 24-hour urine protein collection in initial visit. Proteinuria and creatinine are more sensitive than hematuria for prognosis. Urine analysis should be included in every visit. Reappearance of glomerular hematuria or cellular casts can be a prediction of impending kidney flare. Renal activity index for lupus nephritis RAIL that has been presented in ACR 24 based on urinary concentrations of 6 urinary proteins that are discriminatory for lupus nephritis. RAIL scores identify lupus nephritis activity as on kidney biopsy. Renal responses, we can get either complete renal response, partial renal response, or no response. The complete renal response is defined by urinary protein creatinine ratio of 500 milligram per day or less with normal or stable GFR. Partial renal response, at least a 50% reduction in urinary protein creatinine ratio compared to baseline, but above 500 milligram. In the presence of nephrotic range of proteinuria, which is 3,000 or more milligrams, then a 50% reduction, and to less than urinary protein creatinine ratio 3,000 should be evident with a stable or normal GFR. No response is neither complete renal response or partial renal response. The last topic is the glucocorticoid toxicity index. This has been proposed and published by a group of experts in outcome measures, and the first author of this publication was John Stone. You know him, of vasculitis clinic of Harvard Medical School. They say in the introduction of their paper, glucocorticoids have been the cornerstone treating dozens of inflammatory conditions for more than 7 decades. Toxicities associated with glucocorticoids are central to patients with inflammatory diseases. There has been no practical, reliable means of calculating the degree to which glucocorticoid toxicity worsened or improved. One of the goals of novel therapies for inflammatory disease is to diminish effects of glucocorticoid toxicity, thereby differentiating new treatment approach from current standards of care and justifying their value for society. A search of clinical trial government on the term glucocorticoids yields more than 6,000 clinical trials between 2001 and 2021. Not a single one employed a validated instrument to assess the impact of their treatment approach on glucocorticoid toxicity. More than 45 studies have now licensed the glucocorticoid toxicity index. These are studies in SLE, ANCA vasculitis, polymyalgia rheumatica, giant cell arthritis, asthma, pemphigus vulgaris, bullous pemphigoid, IgG4 related disease, Behçet, sarcoidosis, myasthenia gravis, Kawasaki, GIA, and inflammatory myopathies. Glucocorticoid toxicity index, developed by international group of subspecialty physicians, experts in clinical outcome instruments, is the first standardized validated measure of glucocorticoid toxicity. GTI purpose is to measure change in glucocorticoid toxicity between 2 points of time. For example, between the baseline visit and the time of the primary efficacy outcome assessment. It is designed to quantify both worsening and improvement in glucocorticoid toxicity by calculating 2 scores, cumulative worsening score or aggregate improvement score. These are the domains. I know that we do not do a lot of clinical trials in Egypt, but I wanted to show you this because these domains can be put in our minds and we can easily see them in our clinical practice and follow them. It's body mass index, very easy, blood pressure, very easy, glucose metabolism, lipid metabolism, bone mineral density, glucocorticoid myopathy assessed by strength of shoulders and thighs, skin toxicity assessed by acne, striae, hirsutism, and easy bruising, neuropsychiatric effects like insomnia, depression, steroid-induced violence, and the infection. Thank you.
Thank you, Professor Kamel. A difficult mission, well established, well handled. Thank you very much. Now, as we have known how to measure disease activity indices, how to evaluate organ damage in our lupus patient, we need to know in details how we're gonna treat our lupus patients. It's my honor to present Professor Dalia Faiz, my professor and my eldest sister as well, and my mentor. I have many mentors in the department. I'm very lucky. Professor Dalia Faiz will introduce to us into details the latest EULAR recommendations for treatment in systemic lupus erythematosus. Professor Dalia.
بسم الله الرحمن الرحيم. أشكركم على الحضور وأشكر شركة أسترا for sharing of this difficult session. Today I will speak about update EULAR recommendation in detail for SLE critical view. Dr. Carlos, I will speak in Arabic beside English, please. Okay. As we know that SLE is a systemic disease, autoimmune disease with polymorphic manifestation and a lot of antibody against nuclear antigen. It can affect skin, heart, mental, lungs, blood, kidney, and musculoskeletal. Start with the EULAR recommendation 2023. It includes 5 overarching principles and 12 and 13 recommendations. First one, في overarching principle, SLE require multidisciplinary individualized management with patient education and shared decision between a patient and doctor is very important, and multidisciplinary with other specialty. زي دكتور محمد صلاح والدكتور كامل ما قالوا SLE disease activity should be assessed at each clinic visit. The frequency depends on stage of the disease, well, the presentation of this of the patient, and according to the physician discretion, with evaluation of organ damage at least annually, and using validated instrument اللي قال عليها دكتور كامل. We must explain to our patient non-pharmacological intervention, including sun protection, smoking cessation, healthy balanced diet, regular exercise, and measured to promote bone health to avoid osteoporosis. All of these are important to improve long-term outcomes. And later on, pharmacological intervention directed by patient characteristics, type and severity of organ involvement, treatment-related harms, comorbidities, risk for progressive organ damage, and shared decision, patient preferences, need injection or oral tablet. The last overarching principle is trying for early SLE diagnosis, including serological assessment, regular screening for organ involvement, especially nephritis, prompt initiation of treatment, aiding of remission, or even low disease activity if remission is not possible. And also strict adherence to medication to prevent flare and organ damage and improve the prognosis and quality of life. And this is the drug used in SLE from 1948 up till now with the use of biologic therapy. The goal of remission اللي هتحكي لنا هتقولها لنا دكتوره سماح. The goal of remission to lower risk of damage occur, lower risk of cardiovascular event, lower risk of disc, better quality of life, and increase the chance of glucocorticoid discontinuation. This is the recommendation, about 13 recommendations with level of evidence. عندنا من 1 to for it, including the proper management, the drug used in the management, and from 5 to 12 about how specific treatment of organ affected, and the last one, it is adjuvant therapy and treatment of comorbidities. They focus on 5 domains: management of general and organ-specific SLE, the target of treatment, a tapering and withdrawal of treatment, management of patient with SLE and antiphospholipid, the efficacy and safety of vaccination against herpes zoster, against the COVID viruses. And the other recommendation for infection prevention, it is included in another topics. Recommendation number 1, hydroxychloroquine is recommended for all patients unless contraindicated. عشان كده احنا بنعمل للعيان baseline fundus examination عشان نشوف في عنده macular defect، لو عنده renal impairment لازم نعمل assessment عشان البروبر دوز اللي هو ال 5 مللي جرام بر كي جي بودي ويت. العيانين اللي هياخدوا اقل من 5 مللي جرام increase flare، والعيانين اللي هياخدوا اكتر من 5 مللي جرام هيبقى more retinopathy. But don't afraid as regard retinopathy. And when the patient enter in remission, don't stop hydroxychloroquine. Don't be afraid about retinopathy لان الستاديز كلها اتعملت. البروسبكتيف ستادي قالت البريفالنس اوف retinopathy about 2 to 4% at dose of 5 ملغ per kg at 15 years. يبقى no need ان انت تقول للعيان اعمل fundus examination every 3 to 6 months. And this is the proper dose, and this decrease incidence of flare. Glucocorticoid act as a bridging therapy to induce remission, and especially in patients with moderate to severe, you can use pulse steroid, methylprednisolone from dose 125 to 1000 milligram per day for 1 to 3 days, and no need to increase the dose and increase the days of methylprednisolone. Methylprednisolone, it improve and progress remission, rate of remission, especially renal remission, but on the expense of increase serious infection and increase mortality. Recommendation number 3, in patients with not respond to hydroxychloroquine and glucocorticoid, start with immunosuppressant according to the stage of the disease, methotrexate, azathioprine, macrolide, mofetil, or even biologic therapy. In EULAR 2019, can steps line 1, 2, 3, but in EULAR 2023, you can give combination of therapy according to the stage and presentation of the disease. In patient number 4, in patient with organ-threatening, life-threatening disease, don't be hesitated to start with intravenous cyclophosphamide, or even in refractory cases, rituximab may be considered. هنبدأ بقى skin organ. Treatment of active skin disease should include topical agents, glucocorticoid, calcineurin inhibitor, anti-malaria, اللي هو الهيدروكسيكلوروكين او كلوروكين، systemic glucocorticoid, methotrexate, microlide, mofetil, aliflunab or belimumab as a second line therapy. في الاكتيف neuropsychiatric, you start with methylprednisolone, glucocorticoid, and inflammatory and immunosuppressive for inflammatory manifestation, and antiplatelet or anticoagulant for thrombotic antiphospholipid related manifestation. Number 7, for acute treatment with severe autoimmune thrombocytopenia, we start with high dose glucocorticoid اللي هي البالس ستيرويد، rituximab, IVIG, intravenous cyclophosphamide. You can use rituximab as a maintenance therapy, and later on azathioprine, mycophenolate, cyclosporine should be considered. In patients with active proliferative lupus nephritis should receive الإيورو لوبس اللي احنا بندي 5 ملغ مثال cyclophosphamide every 2 weeks, or mycophenolate mofetil beside intravenous methylprednisolone, then decrease the dose of steroid. Combination, we could combine with belimumab, or cyclophosphamide, البيبرماب could be combined with cyclophosphamide or mycophenolate mofetil, or could be combined with calcineurin inhibitor اللي هو فوكلوسبور اور تاكلورينس. وزي الدكتور محمد صلاح المتوفر عندنا هو التاكرولينس. الهيماتولوجيكال مانيفستيشن حبيت احط لكم عشان برضو يعني مور كونفirmation. الهاي جلوكوكورتيكويد في الحالات الثرومبوسايتوبينيا والهيموليتيك انيميا جلوكوكورتيكويد immunosuppressive في الريزيستنت كيسز اي في اي جي ان سي دي 20 كومبلمنت انهبيشن. وفي الهيموليتيك برضه immunosuppressive سايكلوسبورين اور انتي سي دي. في ده الجايد لاين واتقالت قبل كده، مش هنخوض فيها، بس احنا على حسب الاكتيفيتي اندكس اللي قالها دكتور كامل حشمت. مايلد يعني ايه، ومودريت يعني ايه، وسيفير يعني ايه. مايلد العيان عنده كونستيشن سيمبتومز مايلد، عنده السكين افكشن اقل من 9% في البودي سيرفيس اريا، عنده السليداي من اقل من 6. المودريت بيبقى البودي سيرفيس اريا اكتر من 9 ل 18. البايلاج بتبقى اكتر من 7. السيفير بيبقى فيه ميجر اورجان افكشن زي النيمونايتس، زي السيربرايتس، مايلايتس، وبيبقى السليداي اكتر من 18 والسكين افكشن اكتر من 12. الى جانب البليتلت هنا بتبقى من 50 ل 100، هنا بتبقى من 20 ل 50، هنا بتبقى اقل من 20,000. ودي برضو التريتمنت اوف لوبس نفرايتس ذكروها ان احنا كل العيانين هيدروكسيكلوروكين، في الحالات السيفير بندي انترافينوس مثال برنيزولون، بندي ماكفينوليت موفيتيل او يوروبيان سايكلوفوسفامايد مينتنس بالازاثايوبرين او مينتنس بالمايكفينوليت موفيتيل والازاثايوبرين. ممكن في ريزيستنت كيس ندي ماكفينوليت مع كالسينين انهبيتور، او ندي هاي دوز سايكلوفوسفامايد اللي احنا بندي اكتر حاجه في الريفراكتيف كيسز بندي الريتوكسونات. ايه الباد بروجنوستيك اللي انا على طول ابدا بالاجريسيف ثيرابي لما يبقى العيان عنده ريديوسد استيميتد جلوميرولار فلتريشن ريت، هيستولوجيكال بريزنس اوف cellular crescent of fibrinoid necrosis with severe interstitial inflammation. Don't forget the EULAR recommendation of non-pharmacological management, sun protection, psychological assessment, regular exercise, and also program for exercise in patient with lupus. Recommendation number 9, following renal response هنحصل ايه؟ Treatment of lupus nephritis ما نوقفش. Should continue for at least 3 years and patient initially treated with mycophenolate mofetil or combination with belimumab or calcineurin inhibitor يكملوا 3 سنين. انما العيان اللي خد سايكلوفوسفامايد maintained بمايكفينوليت موفيتيل or azathioprine. البيشنت اللي عنده هاي ريسك اوف رينال فيلر اللي احنا قلنا عليها ريديوس جلوميرولار فلتريشن ريت، هيستولوجيكال بريزنس اوف سيلر كريسنت، فايبرينويد نيكروزس، سيفير انترستيشال انفلاميشن، بندي هاي دوز اوف سايكلوفوسفامايد مع الانترافينوس مثال بريدنيزولون. البيشنت ويز دخل في ريميشن هنعمل جراديوال تابلينج فيرست اوف كورتيكوستيرويد اند ذن اميونوسبريسنت. البيشنت اللي عنده ثرومبوتيك انتي فوسفوليبيد سيندروم لازم should be managed مع long term vitamin K antagonist after the first arterial unprovoked venous thrombotic event, low dose aspirin 75 مللي جرام per day. ده العيانين اللي هي عندهم thrombotic event. You can use anti prophylactic اللي هو الاسبرين في العيان اللي عنده anti phospholipid but asymptomatic. يبقى احنا بنعمل risk stratification, detection of antibody, and then risk modification by treatment of patient. الفينس ثرومبوزس الاي ان ار التارجت بتاعي بتبقى 2 to 3، في الارتيريال ثرومبوزس التارجت بتاعي 2 to 3 and even 3 to 4، او تديله لو دوز اسبرين ويبقى التارجت بتاعك 2 to 3. في حالات الثرومبوتيك انتي فوسفوليبيد لازم ندي كومباينيشن هيبرين جلوكوكورتيكويد بلازما اكسشينج اور اي في immunoglobulin. في المايكروفاسكولار مانيفستيشن الانتي كواجولانت والانتي بليتلت مع الاميونوسبريسنت. في حالات الريزيستنت في النون امبروفمنت لو هو ثرومبوتيك مايكرو انجيوباثي give anti-CD20 or complement inhibition, diffuse alveolar hemorrhage, IVIG or plasma varices or anti-CD, levoid vasculopathy, NCD, IG with diveridumone. Last recommendation in immunization for prevention of infection against herpes zoster virus, human papilloma virus, especially في childbearing period, against COVID and the influenza and pneumococcus. Management of bone health, nephroprotection, cardiovascular risk, and screening for malignancy should be performed. لسه في existing topics لسه under research من الجروب of يولار accordingly ايه في حاجات ناقصه لسه بيعملوا لها research utility of measurement of drug blood levels المايكلونيت وفتيل والهيدروكسيكلوروكين والسايكلوفوسفامايد a trial for different doses of initiating glucocorticoid and intabering الoptimal dose of therapy and timing of immunosuppression and discontinuation الفاليو اوف ريبيت كدني بايوبسي عايزين يعملوا كدني بايوبسي كل سنه وقبل ما يوقفوا كمان يعملوا كدني بايوبسي to be sure about immunological and pathological remission. Value of a protocol of repeat kidney biopsy. يا اسف انا قلتها. Prediction of flare. Prediction of flare in patient who reach target and use of other medication statin والrole of to prevent the cardiovascular. هم برضو كانوا اليولار كانت ادريس الكلاسيكال انفلاماتوري لوبس مانيفستيشن كانوا مركزين على التايب 1 اللي هو الانفلاماتوري سيمبتوم باي يوزنج اوف immunosuppressive وبرضه ما ركزوش على التايب 2 اللي هو نون انفلاماتوري اللي هو الفاتيج والمود ديستربنت والكوجنيتيف ديسفانكشن ما برضه عايزين يدوروا على الريسك ستراتيفيكيشن اند هاو تو بريفنت الاوكرنس اوف لوبس ودي الايرا الجديده التريتمنت اوف بري lupus to define patient who at risk of development of lupus ايه السبيسيفيك ثيرابي ايه الاورجن ايه الدراج اللي افكت ذيس اورجن ايه السيتوكاين اللي بيأفكت اورجن اند leave other organ هم عايزين يعالجوا اللوبس at the stage of the preclinical lupus and يشوفوا الجينيتك ريسك سكور ويحددوا الجينيتك insight for initiation of for initiating immunopathology عايزين يعملوا يشوفوا الجينيتك ترانسكريبتيف ستيج اللي بتخلي العيان to develop lupus. بعد كده الاي سي ار كمل على الايولار as regard lupus nephritis وكان الايم بتاعهم البريزيرف كيدني فانكشن والكولابوريتيف ورك مع النفرولوجيست اللي هي shared decision between rheumatologist and nephrologist وقالوا ان كل العيانين لازم سكريننج يعملوا شيك بروتينوريا every 6 to 12 months at time of clinical flare ولازم يعملوا رينال بايوبسي في لو هم العيان كان عنده بروتونوريا او نوت ريسبوند للتريتمنت او حصل له فلير وريكومند يوز هيدروكسيكلوروكين for all patient and protective measure by renin angiotensin system and don't forget الادجuvant therapy. وبرضه نفس القصه ركزوا على البالس سترويد ان هو ان سمول دوز وديكريز دوز لحد ما نوصل اقل من 5 مللي جرام ودي الجايد لاين اللي قالها از ريجارد زي ما دكتور صلاح قالها ان احنا في تايب 3 اور 4 ستارت ويز تريبل ثيرابي مع اللي هو البالس والبليبروماب والكالسينولين انهبيتور اور الترناتيف اللي هو البالس او سايكلوفوسفامايد بيسايد بليبروماب في حالات الستيج 5 ستارت برضه بريفيرد بتريبل ثيرابي بالس مع مايكوليت مفوتيل مع كالسينيولين انهبيتور لو نوت ريسبوند الالترناتيف ان احنا ندي مع البالس مايكوليت مفوتيل مع بليبوماب او ندي له دوز سايكلوفوسفامايد مع البليبوماب والتوتال ريكومنديشن برضو كانت 3 to 5 years we don't do rapid discontinuation of therapy وهم recommended to do renal biopsy before discontinuation of therapy زي ما قلنا to confirm pathological remission. في حالات lack of response بنستخدم alternative therapy. في حالات الريفراكتوري disease لازم نعمل consider adherence او consider associated comorbidity زي الانتيفوسفوليبيد نفروباثي او advanced chronicity and you can do another therapy اللي هو الانتي سي دي 2 وزي الدكتور محمد صلاح ما قال ان في برضه الانتي دي 2 اللي هو الاوبنيتوزوماب. And in case of end-stage renal disease, it is better to do early renal transplantation. And thank you.
Thanks, Professor Dr. Dalia Faiz, for this illustrative, practical presentation about the ELR and the ACR recommendations for management of systemic lupus. The next presentation, Professor Dr. Samah Abdurrahman, Professor of Rheumatology and Clinical Immunology, Department of Medicine and Shams University, Cairo, Egypt, will present treat to target, which is a very important topic, treat to target recommendation for management of systemic lupus erythematosus.
بسم الله الرحمن الرحيم. I'm privileged to participate in this workshop with my eminent professors. As well, I am welcoming Professor Tariq Salman. He's leading one of the important SLE centers in Barcelona. And it's my time now to stress on the importance of treating to target. You have already heard the recommendations for treatment. By now, you know how to assess your patient's disease activity, the damage indices, and we have to put a target, because when we have a target, we are focused and we can use the data we know to reach this target. And treat to target had been extrapolated from internal medicine at the beginning of this century, and we started by rheumatoid arthritis, then psoriatic arthritis, going through axial spondyloarthropathies, where they launched the treat to target strategy in 2017. And it's time now to know the target in treating patients with systemic lupus. And as we doing so, we have to consider some points. We have to consider the individual clinical data of each patient. It's personalized treatment strategy. We have one target, which is remission or low disease activity, but in doing so, we personalize the treatment strategy for our patients. And by this, we can adjust our medications as needed by assessing our patient at fixed time intervals to know how we stand in our way in controlling this disease activity. And you already know on clinical backgrounds, on actual backgrounds, that we do not achieve disease remission or even low disease activity in many of our lupus patients. It has been published that only 20% or less of patients of lupus achieve low disease activity and less than 15 achieve remission. And this is a difficult task to do. But it is very important to put it in mind. Why? Because when you achieve disease remission or at least low disease activity, patients will have less flare attacks. We will minimize the dose of corticosteroid, which is now, as we have available tools to use, is very important to achieve, to decrease the dose of steroids, and as well treat the patient as well as treating the disease, so our patients will have good quality of life, less fatigue, less pain, and more quality of life. In doing so, we have to use the overarching principles that were applied by the latest EULAR, which has been just mentioned by Professor Dalia, that we have to put in mind that treating systemic lupus is not a one-man show. It is a multidisciplinary play with different specialties, neurologist, nephrologist, mastered by the rheumatologist. We have to know the disease activity indices at the beginning of our treatment, assess this at time, milestones every 3 months, putting in our mind our target, which is disease remission or low disease activity, stressing on the non-pharmacological instructions because they are not less important than the pharmacological treatment that we will apply to our patients, because by now we have many pharmacological tools to play with to achieve our mission. Early diagnosis is very important. That's why continuous medical training and education about how to diagnose, how to treat, how to assess lupus activity is very important. Early initiation as per recommendation is very important. Early aggressive treatment, if you have poor prognostic factors, is very important, and these will be the instructions in reaching your targets. As mentioned by my dear professors, that the latest recommendation was unique in stressing on the target and defining this target, which is either disease remission or low disease activity, and disease remission is defined by the Doris definition, as Professor Kamel Hashmat mentioned. We should have clinical CDI equal 0, hopefully, patient global assessment less than 0.5, and low steroid dose less than 5 milligram per day, which is, I think, a dream to all of us. Do you have patients, Professor Tariq, on less than 5 milligram per day in your center? Some? By achieving this disease remission, definitely we will have less organ damage, fewer flares, reduced time for hospitalization, and improving the quality of life of our patients. It is also important how long our patients will be in remission. And the longer the patient is in remission, the fewer the disease flares in the near future. And here you can see that patients on disease remission for longer times have better rates of, or lower rates of flares than those that spending 25% of their times in disease remission or less. Definitely, the longer time your patient is in disease remission, the less organ damage. Because we know lupus is a systemic disease, and we have vital organs that are affected in lupus: the CNS, the kidney, the heart. So we need to put our patients into disease remission or low disease activity to prevent organ damage. And this has been documented by many studies in many centers, that the longer our patients are in disease remission, the better. Even if you are able to put your patient in disease remission or low disease activity in 25% of their time of the disease, this is better than nothing. And if our disease remission is not achieved, our alternative is low disease activity, better than nothing. Because, and as you have heard Professor Kamel Hashmat, it's not only the organ affected, it's not only the inflammatory markers that are elevated, it is the dose of glucocorticoid that is accounted in our disease activity indices. So we need to go into disease remission or low disease activity, and this by means of decreasing the corticosteroid dose, decreasing the inflammatory markers for better prognosis of our disease. A low disease remission, as Professor Kamel mentioned, is by the Asia Pacific Lupus Collaboration in 2016 وده كان الديسكريبشن بتاعه ان الديزيز اكتيفيتي عشان اقول ان البيشنت ده ان لو ديزيز اكتيفيتي السليداي 2K should be less than 4 without major organ affection. No new systemic lupus disease activity and the Selena SLEDAI physician global assessment should be less than 1%, and always our patient should be on stable immunosuppressive medications with no non-standard doses. يعني ما بقاش بستخدم الاوفر او increased doses than standard to control disease activity. And definitely as disease remission, low disease activity for long periods will reduce by time السلداي 2K هيقلل الاورجن damage. By time we will have more patients on low corticosteroid dose, and this will decrease the mortality as well as decrease the rates of lupus flares and increase the survival rate بتاع العيانين along with improving their quality of life. وفي الحقيقة يعني احنا if we at least achieved low disease activity in patients for about half of their time of the disease, the survival rate will increase and the disease severity and probability of more flares will decrease. As shown here, in patients with low disease activity have less severe disease and flare attacks than those with non-low disease activity, as well as they have better survival. And the decrease in disease activity flares is actually decreased by half if we maintained our patients in low disease activity. At least their flare attacks will decrease by half. And it is already, it's not a notion or a suggestion, it has been already confirmed by different trials from different centers along the world that achieving remission or low disease activity definitely reduces the organ damage, decreases the risk for hospitalization, improves the quality of life, and it reduces mortality as well. By not doing so, you will risk that your patient will be in more flare attacks, high doses of immunosuppressives, and high doses of steroids that will definitely increase the patient global assessment, increase the possibility of more aggressive organ affection and organ damage, and will increase the mortality probability as well. But the important point here, while we are achieving the disease remission or low disease activity, which perspective should we look for? For the patient perspective, they need to have to regain their normal life, have a good quality of life, regain their activities without flares. Practically, we can see this in some patients even if they are not achieving the score itself. We see patients that on doses of corticosteroids maybe more than 5 milligrams, maybe 10 or 7.5, on more than one immunosuppressive, but yet they having good quality of life. They having no frequent flares. So we have to balance between our perspective and the patient perspective for disease remission and low disease activity without using much aggressive treatment that might affect by the end the patient's quality of life. So remission is the target. The alternative target is low disease activity. And the therapeutic targets, we have many tools to use nowadays for achieving these targets, and the EULAR recommends that we can use all our tools to induce disease remission or low disease activity as early as possible to prevent organ damage and improve the quality of life of our lupus patients. Maybe For the coming 2 sessions, we will discuss how we can practically reach low disease activity or disease remission in our patients by using the available tools we have now in Egypt. Thank you.
Thanks, Professor Dr. Samah, for this presentation about the need to target, which is important topic in management of systemic lupus. Next, we present practical cases for discussion care beside consultation by Professor Dr. Dalia Faiz.
احنا كده خدنا how to diagnose الباثوفيسيولوجي, how to diagnose, assessment tool, how to manage. هنبدأ الجزء بتاع الكلينيكال application. I will discuss 2 cases. Egyptian case, وهعرض عليكم اللي اتقال في الاي سي ار as regard lupus nephritis. First case, Ahmed, 21 years old, male patient, non-smoker, student in College of Engineering, has SLE since 2023. His illness started with dyspnea, fever, palpitation, hypotension, polyarthritis, vasculitic rash, alopecia, edema in lower limb with marked weakness and fatigue. On admission, he has carditis, nephritis. His workup, hemoglobin 9.5 gram, normocytic normochromic, leukopenic 3.5, platelet 120, ESR 120, creat normal, uric acid normal, protein creat ratio 1.5 gram, ANA positive, DNA positive, low complement, negative anticardiolipin but positive lupus anticoagulant, high ferritin level. On doing renal biopsy, it showed focal proliferative glomerulonephritis, activity index 8/24, chronicity index 3/20. Echo show picture of cardiomyopathy, global hypokinesia, mild mitral regurg, mild pericardial effusion, ejection fraction was 27%. السلداي activity 33. طبعا عملنا اللي قال عليه دكتور كامل. البايلج accordingly احنا قلنا organ affected. البايلج كان A for mucocutaneous and procedural symptom and musculoskeletal, and B as regard cardiorespiratory. He received pulse steroid and cyclophosphamide 6 cycle, and then maintained on mycophenolate mofetil, steroid hydroxychloroquine. We start at this young age by cyclophosphamide because we need to enter in remission and prevent organ damage. He entered in remission till 2025. After 6 months of therapy, patient improved clinically and laboratory. Hemoglobin عالي بقى 12, total leukocytic count 6, platelet 240, ESR descend to 20, protein creat 0.24, C3 و C4 normal. أحلى حاجة بقى الإيكو ejection fraction started to rise from 54% to 72%, still negative antiphospholipid. السليداي نزل من 33 ل 2. البايلج بقى D for renal. البايلج بقى D for everything and B for renal improvement. يعني احنا عايزه اقول لكم ان الاكتيفيتي لازم نعود نفسنا على الاكتيفيتي اندكس لانها very difficult to measure. He started in 2025. He started to complain of areas of hair loss with polyarthritis of both hands and knee. He has bilateral knee effusion and alopecia. He became depressed with increased absence days from his college and failed in his term exam. No renal failure. And follow-up of echo was good. Ejection fraction is still 75%. ESR 50 C3 و C4 normal. He is on steroid 10 milligram, hydroxychloroquine, mycophenolate, mofetil, SLEDAI raised to 8, Bilag C for mucocutaneous and A for musculoskeletal. What's the next step for this patient? ايه رأيكم؟ We prescribed the anifrolumab for him. Safanello given him in 300 milligram infusion within 30 minutes. He just received up till now 2 cycles and still ongoing treatment. There was up till now improvement of symptoms. الالوبيشيا انا مش عارفه الصوره واضحه ولا لا. الالوبيشيا markedly improved. Second case, female patient 32 years old, married and has 2 children. Her illness started since 2016 when he was in her college by skin lesion on her cheeks. She presented to clinic where investigation proved SLE. She has alopecia, anemia, high ESR, ANA positive, DNA positive. So she has hematological and skin lesion with no other organ affection. الورك اب بتاعها لا ده بعد كده. في الوقت ده she received steroid hydroxychloroquine and methotrexate but she couldn't tolerate methotrexate لان كان الكونديشن عندها just mucocutaneous. She couldn't tolerate methotrexate, so we shifted to azathioprine. Azathioprine induced leukopenia for her, so we shifted to mycophenolate mofetil. She was in remission till 2020. After marriage in 2020 and got her kids, and under psychological stress start flare in 2024. And الورك اب بتاعها لما جالها فلير هيموجلوبين كان 7.5 جرام بر ديسيليتر، total leukocytic count 2.5, leukopenia and platelet 180, creat 0.6, uric acid normal, protein creat 0.2 جرام بر ملي جرام. الاي ان اي بوزيتيف والدي ان اي بوزيتيف والنورمال سي 3 وسي 4 والاي سي ال اي الانجي كاردليبين نيجاتيف اللوبس انجي كواجول نيجاتيف شيست اند هارت نورمال السليداي كان 9 البايلاك بي فور هيماتولوجيكال اند ميوكوكوتينز. So there was a flare of lupus activity. She presented with fever, marked loss of weight, subacute scarring lesion with marked alopecia and polyarthralgia. Hemoglobin بتاعها 8.5, total leukocytic count 2.8, platelet 132, ESR 130, C3 و C4 normal, antiphospholipid negative, renal والliver normal, no proteinuria, SLEDAI اترفع ل 10 البايلاج A for mucocutaneous, C for hematological and musculoskeletal. This is after flare of his skin lesion and her face and her scalp. She received rituximab with no improvement of skin lesion. She was severely depressed as her husband doesn't like to live with her anymore. How can we help this lady to continue her marital life? She received mycophenolate mofetil, rituximab. The answer is we are still trying to give her anifrolumab. Deal other 2 cases from the ECR as regard lupus nephritis. Professor Maria presented to us 2 cases. The first case, 29 years old woman with a 3-year history of SLE, inflammatory arthritis, alopecia, ANA positive, DNA positive, presents to clinic with worsening of joint pain, stiffness, and fatigue. She received hydroxychloroquine and prednisolone 3 milligram per day. Examination, blood pressure hypertensive, pulse normal, heart and lung normal, swelling and tenderness for bilateral wrist, second or third metacarpophalangeal and several proximal interphalangeal joint. Lab, there was leukopenia 3.4, hemoglobin 9, platelet 150, high ESR decrease في estimated glomerular filtration rate, positive anti-DNA high titer, C3 decreased, urine analysis RBCs positive, white blood cell negative, protein creat ratio 1 gram, it was 0.2. What's the most appropriate next step in the evaluation and management of this patient? تفتكروا ندي العينه دي هنا in Egypt ايه؟ according للavailable medication لينا. Yes. Prompt kidney biopsy is a first step for diagnosis and classification before start any protocol. And then prompt treatment with glucocorticoid. She said, don't wait for the result of renal biopsy. Do renal biopsy, start methylprednisolone. Kidney biopsy show class 4 lupus nephritis, activity index 6, chronicity index 2, and 1 crescent. After discussing her new diagnosis of class 4 lupus nephritis, second step if management is a shared decision. You describe various therapeutic options to the patient. She tells you that she is worried about her kidney and is interested in future pregnancy. She is frustrated by her ongoing inflammatory arthritis, which is impacting her ability to work. She says that intravenous infusion would be difficult for her due to her work travel schedule. What do you recommend as a therapeutic management for your patient? MMF. Yes. She recommends triple therapy, glucocorticoid, mycophenolate mofetil, and belimumab. It is just a monthly intravenous therapy. Beside protective by renin-angiotensin, continue hydroxychloroquine. Special consideration doesn't want intravenous medication, ongoing active inflammatory arthritis, and also desire for future pregnancy, beside the protein creat 1 gram. Second patient, 31 years old woman with a 2-year history of lupus, prior inflammatory arthritis, alopecia ANA positive, DNA positive, present to clinic with nocturia and foam urine. Medication by hydroxychloroquine and prednisone 3 mg. يظهر 3 mg ده ثابت عندهم. Blood pressure 150/90, pulse, heart, lung normal, bilateral lower limb edema, +1 proteinuria, lab +1 sorry bilateral lower limb edema, white blood cell leukopenic, hemoglobin anemia, platelet 160, ESR 100, estimated glomerular filtration rate 60, decreased, anti-DNA positive, C3 consumed, urine analysis RBCs positive, white blood cell negative, spot 4 gram of proteinuria. Kidney biopsy show class 4 and 5, activity index 5, chronicity index 1. She tells also you that she is very worried about her kidney and is interested in future pregnancy. She says that intravenous infusion would be difficult for her due to her work travel schedule. What do you recommend? If the patient in Egypt, what do you recommend as a therapeutic management plan? Yes, calcineurin inhibitor. This is the best for her. She recommends treatment approach triple therapy, glucocorticoid, mycophenolate mofetil plus calcineurin inhibitor, lung renal protection, and continue hydroxychloroquine. A special consideration for this patient, protein high level of proteinuria, doesn't want intravenous medication, and the desire for future pregnancy, no active extra renal manifestation. And we need aggressive therapy to improve the outcome and protect nephron from destruction and protection from against nephron loss. And thank you for your attendance.
Thanks, Professor Dr. Adalia, for this interesting cases. Now, Professor Dr. Samah will present We presented the role of biologics in management of systemic lupus and other challenging cases. دكتورة سماح اتفضل.
بسم الله الرحمن الرحيم. I will start my talk by highlighting or mentioning some of the biologics. Professor Salah mentioned a lot of biologics that are already present or in the pipelines, but I will talk about the already present biologics we use, so we can use in our usual clinics. One of the biologics early introduced to lupus patients was rituximab, which is firstly approved for follicular lymphoma, but a lot of trials have been conducted on rituximab, especially in lupus nephritis, with good results. That's why it has been put into the recommendations. And administration of rituximab usually depletes all the CD20 cells, and the patient usually retrieves a naive B cell. But if some patients weren't that much depleted and started to make from their memory cells, they might need more than one dose of rituximab for treatment of their lupus flare attacks. The second biological therapy, another anti-CD20, because for biological therapy in lupus, we can target more than one mechanism of action. The first of which is the CD20 inhibition, and another CD20 inhibition is oportunizumab, and we have oportunizumab in Egypt as well as rituximab, and this is a humanized, not chimeric, right? Like rituximab, this is a humanized glyco-engineered type 2 anti-CD20 antibody, more powerful than rituximab, and it have been went through phase 2 and phase 3 trials in lupus nephritis, the mobility trial in phase 2 and the regency trial, phase 3 trial, which is giving the possibility of this drug to be approved soon as biological therapy for lupus nephritis. Another biological therapy targeting B cell, as mentioned before, is plimumab, which has gained approval for treatment of active lupus in 2011, and we were privileged to be one of the centers in that time. The principal investigator was Professor Muhammad Salah, and we had Professor Dalia Faiz, Professor Dalia Abdel Mohsen, and Professor Nuran Al-Azizi were co-investigators in this trial on plimumab. After which it had حضرتك ناسي؟
ما كانش بليموماب.
امال كان
احنا
ايه؟
اشتغلنا عن تابالوماب اللي did not achieve the primary end point.
معقولة؟
الدواء بتاعنا ما عملش.
ما جابش نتيجة؟
Yes, we shared in Tabalumab trial maybe 10 years ago. But you know, the Tabalumab did not achieve the primary endpoint. Tabalumab did not achieve
ما
primary
كانش
endpoint. Yes,
بليموماب. أنا كنت فاكرة إن ده البليموماب.
it was multi-center trial all over the world, but we did not. Unfortunately, we did not achieve the primary endpoint.
يمكن بقى يجي لنا في phase 4 post marketing. البليموماب كان approved for lupus nephritis في December 2020 according to the PLIS lupus nephritis trial. وفي الحقيقة البليموماب لسه عليه trials تانية. اتعمل عليه الكالبريت trial, which was a combination strategy giving plimumab after inducing remission with cyclophosphamide and rituximab, and this trial was aiming mainly for the safety, and it was found it is safe. If you have severe cases, it is safe to sequentially treat your patient with plimumab after inducing remission with rituximab and cyclophosphamide. As well, the PLES-PLEV study كانت investigating adult lupus patients على ان نشوف the availability او the possibility of controlling disease activity by using plimumab alone, plimumab plus rituximab, or plimumab with standard of care therapy. And this study proved that plimumab was good in controlling lupus disease activity in combination with the standard of care therapies. Another way, because in congresses we have heard that the pathogenesis, and as we heard in early this morning, that the pathogenesis of systemic lupus is not only B cell driven, we have also the pathway of the interferon, and anifrolumab is a monoclonal antibody targeting interferon 1 receptor. Acting on this interferon, this is the first biological therapy to be approved for treatment of moderately to severe active lupus that didn't respond to conventional DMARD after the TULIP-2 trial, which has been conducted for 2 years to prove that anifrolumab was able to reduce disease activity in patients with moderate to severe lupus. Now is the TULIP extension trial studying the efficacy and safety of Safenello in treatment of patients with active lupus. Those exposure adjusted incidence rate كان أكتر من 100 patients per years ده في الإكستنشن، وكان عندهم ما فيش opportunistic infection. في الحقيقه فيز 3 الايريس ترايل اللي كانت معموله على السافينيلو كانت بدات تو ايفالويت. احنا عارفين ان السافينيلو ابروفد فور مودريت تو سيفير اكتيف لوبس not with lupus nephritis. فالايريس فيز 3 studying الانافرينوماب في الاكتيف proliferative lupus nephritis والستدي الريزلتس so far showing that the intensified regimen اللي هو 900 milligram is doing better in controlling lupus nephritis as well. There is ongoing trial recruiting دلوقتي double multicenteric double blinded placebo control trial على الانافرينوماب علشان to evaluate الefficacy والsafety of subcutaneous route. And Professor Tariq Salman told me that his center is one of the centers studying the subcutaneous anafrolumab. Yes, yeah. But it's not only anafrolumab that is you have many targets for the interferon pathway, and the trials now is going because this is a potential pathway to work on. دلوقتي احنا عندنا studies targeting the plasmacytoid dendritic cell, which is the mother cell producing interferon. Many targets are in the pipelines to be studied. Litifilimab is a humanized IgG1 antibody against plasmacytoid dendritic cell in phase 2 trial, mainly in severe cutaneous lupus. Other biological therapies have been studied. في الحقيقة they يعني tried interleukin 6, they tried interleukin 12-23 and the study was not completed علشان it didn't reach the primary endpoint. But targeting complement is as well an interesting route to use. Icuzumab, fully humanized antibody against complement 5, may be used. It's not a traditional drug to use, but it may be used in lupus patients associated with thrombotic microangiopathic hemolytic angiopathy or hemopoietic stem cell transplantation associated with thrombotic microangiopathy. وفي الحقيقة رغم ان كل الأدوية دي اللي موجودة, only what have been approved is Limumab and Anafrolumab that are FDA approved and are mentioned in the recommendations. And rituximab, though it's not approved, but due to the extensive trials that have been done on this drug, it have been also put in the treatment paradigm of patients with active lupus nephritis. I'm here to share with you 3 cases of anafrolumab since it have been introduced here in Egypt. The first case is a 51 years old female lupus. She has hypothyroidism on replacement therapy since 2015. This patient had no diabetes, no hypertension, and no habits of medical importance. This patient has a little bit long history because she had suffered from benign increased intracranial tension since 2001, was on medical treatment, then she was operated upon by shunt in 2008. She has stable condition till 2012 when she suffered from photosensitivity, and according to her words, it was said to her that this is due to her fair skin. Then from 2016, she started to complain from chronic normocytic normochronic anemia, and she was as well on hematinics. And she was on the treatment for the increased intracranial tension till she had two revision surgeries on her shunt till 2022 when she had an attack of loss of consciousness, incontinence. The patient was hospitalized and was diagnosed to have Addison's disease along with the hypothyroidism, and was put on a replacement therapy. In 2023, she again suffered from severe headache, diplopia, dizziness, and bilateral hand and feet swelling that was arthritis. The patient was hospitalized. At that time, she was well investigated. Her ANA immunofluorescence was high titer. She had positive high titer anti-double-stranded DNA. All her antiphospholipid antibodies were negative, and this was her MRA, MRV, and MRI on the brain showing cerebral vasculitis, beading of her cerebral vessels. The MRI was done first, showing white matter changes. The neurology team have excluded the MS by the visual evoked potential. The cervical spine MRI was contrast, and the lumbar puncture. After appearance of her MRA and MRV, the patient was diagnosed to have systemic lupus, CNS vasculitis, arthritis. She had the photosensitivity as well as the anemia. Her treating physician then used 3 grams of methylprednisolone, 1 gram on 3 successive days for induction of remission, followed by 6 cycles of cyclophosphamide. And the patient presented to me in 2024 on maintenance therapy of 40 milligrams steroids, which is a huge dose of steroids, mycophenolate mofetil 2 grams, hydroxychloroquine 400. She alternated between methotrexate and flunomide for treatment of her arthritis because she had at first elevated liver enzymes on methotrexate. Then she was on leflunomide, but still every time her physician tried to reduce the steroid dose, the patient enters into activity by arthritis, photosensitivity, and she presented with an SLDI score of 16. ده في December 2024, and the patient was, she knew about the treatment of anafrinumab. It was first introduced in Egypt in December. I have put the patient on safenillo 300 milligram per month. Actually, this was the first patient to have safenillo in Egypt. Now, next week, she will receive her 6th dose. These were the investigations in follow-up for the patient, and we can see that she has increase in her C3 and C4. Her SLDI is decreasing, as well as controlling of the anemia. Clinically, the patient is free of arthritis, no photosensitivity. الماجيك بقى ان احنا بعد 6 شهور I was able to taper her steroids. العينة فرحانة جدا انها دلوقتي بتاخد 5 ملغ after being for more than 1 year on 40 ملغ corticosteroids per day. السكند كيس كانت patient 41 years old, healed breast cancer, جالها right sided breast cancer. She underwent surgery, she received chemotherapy, radiotherapy, hormonal, and she's now off therapy. She has no diabetes, no hypertension, but the patient was an ex-smoker. Patient presented في May 2024 بarthritis in both hands and feet and vasculitic skin rash on both of her lower limbs. She has elevated ESR, CRP, CBC كان فيها leukopenia, high titer ANA immunofluorescence. She had no proteinuria. Lupus anticoagulant was negative, but anticardiolipin antibody IgG titer was high as long as with the anti-beta-2 glycoprotein, and she had consumed complement, and the patient was diagnosed to have lupus arthritis secondary antiphospholipid with small vessel vasculitis. After consultation with her oncologist, the patient is stable now and she can receive her immunosuppressant. Induction of remission was done by 500 milligram methylprednisolone for 5 successive days, followed by oral steroids 30 milligram per day, hydroxychloroquine 400 milligram, calcium urine inhibitors, and for the arthritis, she had been cycling between the methotrexate and luflunomide. Both gave her adverse events, so mycophenolate mofetil was added along with antiplatelet, calcium, and vitamin D. Actually, after 4 months, this is the picture of the patient. We were achieving good results with this regimen, but the patient was fed up من التريتمنت. Psychologically, the background of being treated with cancer, she disappeared for about 3 to 4 months, coming again with a frail. But if you notice, we were achieving good results, but we didn't reach that remission at this stage. She didn't wait. She disappeared for 3 months and presented again with active disease, recurrence of her skin of rash, purpuric eruption, recurrence of arthritis. وكانت الانفستيجيشنز بتاعتها العيانه كانت she had active disease, واكشولي هي كانت موقفه الاستيرويدز و she wasn't accepting ان هي to have large doses of steroids. في الحقيقه احنا I have started الصافينيلو للعيانه ديت في يناير السنه دي. she received till now 4 doses, ودي كانت الريزلتس بتاعتها في الحقيقه very good results as regard اللاب الكلينيكال، ان العيانه الفاسكوليتيك راش اختفى، الارثرايتس اختفى، ويكفي انها جت بعد 4 شهور تقول لي انا مش عيانه. I have no pain, I have no arthritis, and I have resumed my normal quality of life. العيانه دي بالذات فرق معاها الكواليتي اوف لايف. ممكن السوشيال ستاندرد sometimes it differs according from patient to another. this patient actually she till now she is in remission and she is appreciating what she have achieved till now with the treatment بتاعها. قدرنا ان احنا نبقى على ستيرويد 2.5، البلاكونيل بقى 200 مللي جرام بير داي، المايكوفينوليت موفيتيل 1.5 جرام، وهي لسه على الانتي بليتلت والكالسيوم والفيتامين دي. Last case ودي الموست recent and this patient had only arthritis. دي كانت female patient 25 years, lupus. She has no diabetes, no hypertension, no medical habits of medical importance. في 2010 هي she presented only with arthritis and was diagnosed to have seronegative arthritis, treated accordingly. But after few months she presented to me with anemia, leukopenia, elevated ESR. Her ANA was high titer and her rheumatoid factor and anti-CCP were negative, and this is a tip. Seronegative arthritis as a diagnosis is much better than seronegative rheumatoid, because seronegative arthritis will give you a chance each time seeing your patient you will ask about more symptoms that may lead you to the diagnosis. But putting the stigmata of seronegative rheumatoid arthritis, you will follow the patient as rheumatoid arthritis. The patient has, at that time, all APS antibodies were negative. There was no lupus nephritis, and she was treated with low-dose steroids, plaquenil, methotrexate, calcium, and vitamin D. We have, I think, Professor Tariq here in our Egyptian patient that they lose control when they are in remission. When they are good, they do not follow up. That's what happened with this patient. She came back in December 2023, again with the arthritis. She got pregnant. She stopped her treatment. She got married. She stopped her treatment to get pregnant. And she presented with arthritis again. This time there was no anemia, but ESR was elevated, complement was consumed, and this time the anti-beta-2 glycoprotein was positive with proteinuria 1.2 gram. The patient has now lupus, arthritis, secondary antiphospholipid with lupus nephritis. She received the methylprednisolone 500 milligrams for 3 successive days, steroids 20 milliجرام. يعني بعد كده after البلس نزلت على 20 ملغ البلاكونيل كالسينيورين انهبيتور الانتي بليتلت والكالسيوم and فيتامين دي. وكان دي الريزلتس بتاعتها، واحنا we have achieved good results with this regimen. But the patient as well, after 3 months, she stopped the treatment and presented again with flare, but thank God it was not a lupus nephritis flare. She had the flare in arthritis, where she needs to get pregnant, and that's why she usually stopped her treatment. So she needed a treatment that will not need that much time to stop. Mycophenolate mofetil was out of the question. She was maintained on the calcineurin inhibitor, the plaquenil, and started السافينيلو for the treatment of arthritis this time. Actually في الحقيقة العيانة كانت giving يعني very good results على الدراج، وهي دلوقتي بتاخد البلاكونيل 200 ملغ calcineurin inhibitor, antiplatelet, calcium and vitamin D, and she's off steroids. يعني أنا my question to Professor طارق بقى هنا how long can أو what about pregnancy on الأنافينوماب؟
This is something I cannot answer because we have no results, but I can tell you how was with belimumab at the beginning. At the beginning, we stopped belimumab until in the moment the girl was pregnant. But now there is a Spanish series because there are 2 clinical assays. You know, it's very difficult for ethics conditions to enroll patients with pregnancy in clinical assays. And there is a registry of belimumab in pregnancy, and also there is a kind of trial. But because of problems of recruiting patients, they were stopped. So we have no results. But you know, the life is more than the clinical trials. So there are a small series like leaving belimumab during pregnancy, and there is no problem. I think it's going to happen the same with anifrolumab, but we still have no data nowadays.
يعني احنا we have many tools to treat our patient with lupus and lupus nephritis. It's how to use these tools to treat your patient, and thank you very much.
Thank you, Professor Dr. Samah, for these challenging cases. We start the open discussion. We reach to the end of this workshop. And any question for Dr. Carlos, Dr. Kamel Heshmat, Dr. Muhammad Salah? Any question about the cases? Yes.
Thank you, dear professors, for this very elegant symposium and presentations. When I reach remission on biologics, how we withdraw these biologics?
Okay, I know this is to me answer this because in Spain, Hakuma pays the treatment, okay? It's totally free for our patients, okay? So I don't stop biological therapy. Firstly, I mean belimumab or anifrolumab. I'm not speaking about rituximab. But if you want an answer to be applied here
Yes.
in Egypt, the first thing should be tapering, okay? But with anifrolumab, we are watching it's going to be better to put low dose than longer the intervals because the biodisponibility of how works anifrolumab. For belimumab, we are making both. In the intravenous way or subcutaneous, we are longer the intervals, or we are putting half dose.
This
Okay.
after the patient reach remission by 6
Okay,
months.
but this is the first time. If you taper the treatment and you have a flare, you cannot continue. You should still put it on biological. Okay? If you reach with a tapering, I think at least 2 years. Okay?
2 years.
Yes, at least 2 years. But with the tapering regimen, you need 2 years of remission with the whole dose, and after 2 years of remission after tapering, and then I will take out the biological. But look, it's not the same one patient without organ damage at the beginning because you don't know how it's going to be in the future. It's not the same as you have a patient of the cardiomyopathy. For this patient, I would never take out the biological. In my way of working, because we don't pay for the treatments, you know. But I understand here is different and you should do something.
Yes, thank you.
Thank you all very much, our eminent professor and our dear guest. My question is for you. You mentioned that the arthritis in lupus is non-erosive, maybe because of the interferon beta. So aren't you worried about a conflict here in the blocking, or does it only blocks the interferon alpha mainly, not the interferon beta, because you will be releasing the osteoclastogenesis?
Yes, but look, we have like several phenotypes of joint arthritis in lupus.
Yes.
And this is one of the theses I'm directing right now, you know.
Yes.
It could be erosive. We have erosive patients, and it's not the overlap between rheumatoid arthritis and lupus. It's called lupus. No,
Yes.
you can have erosive phenotypes in lupus, but you know, we have not been making research in joint disease in lupus. We don't know exactly. There are like 4 phenotypes. You have Jacquard arthropathy, is deformating but not erosions. You have lupus, and you can see in the X-ray. But you have also erosive phenotype. Is not very, very usual in SLE without rheumatoid arthritis and without CCP and rheumatoid factor. Okay, so your question is
about preventing the interferon.
But the thing is, maybe you don't see the erosions in the X-ray, but I'm making MRI to my patients, joint MRI. So I'm now under, I don't know if the erosions in SLE makes irreversible organ damage in the future. This is something we need to now. We are studying now.
Okay, good.
But what I want to make is to put biological in erosive patients with a basal MRI and see in 2-3 years with the biological therapy if we avoid these erosions. But we don't know if there is going to be chronic damage. But look, one thing very important in joint disease in SLE is maybe you don't see the erosions in the X-ray. But if you take one patient with SLE and you don't put biological therapy, or you don't put a good treatment and it's not in remission, 20 years later the hands are deformating. But you can see maybe no erosion. So many things in the joint should be studied.
Thank you. We're looking forward. Thank you.
You say that interferon it has an anti-tumor effect. How can we use belimumab in a lupus patient with a history of cancer, especially the challenging case of Dr. Samah? The patient has history of malignancy and cure. could I use the belimumab in patient anifrolumab in patient with history of cancer?
This is something we need to learn. Okay, we are going to learn like in rheumatoid arthritis. Okay, if you have cancer in rheumatoid arthritis, what should you put? Okay, psoriatic arthritis. I mean, for example, what should you put? Ustekinumab or antitenere? Ustekinumab, yes. So this is something we will know with the years. Now we have the long-term study, and 1 year more. We have 5 years of experience in anifrolumab, and there is no history of tumors. Everyone was afraid about the viral infection because it has antiviral. And you know, with the first, with the Muse and the Tulip one, we were afraid about zoster. But after, with the long-term study, we saw the rates were down. And we are not having severe viruses infections, okay? Even with COVID, more than with belimumab, but it's something that we have not to be worried. We will see with tumors. I cannot answer right now.
In the TULIP 2 study and the TULIP extension, some of the recruited patients had healed cervical cancer, and there was no recurrence of malignancies because especially for this patient, I have revised her treated oncology. She had, because I was thinking about anifrolumab or rituximab. We have no other biologics for her yet. But she needed something that works rapidly. And I have revised with the TULIP study and the extension, and they had patients with cervical cancer, and the extension is more than 5 years. There was no new cases or recurrence in patients. Yeah.
Dr. Kamel, would you recommend and advise to use the activity index indices in our daily practice, because it is difficult to manage and waste our time? Is it important to follow up with the patient by these indices?
Yes, I definitely recommend that, especially with the SLE DAS, which takes only 1 to 2 minutes. You can do it on your phone. You don't even need to use it in the computer. I started to do that to see in a basic clinic how can we manage, especially in doubtful cases. Maybe if you see a case with remission and or just stable as it is, you ignore it. But in some patients where you find some markers of activity and you need to actually address it for more intervention, yes, I recommend that. And as I said, I think it is the future for the either SLE DAS or easy by lag. And I myself, with a busy clinic, I will recommend SLE DAS.
Professor Tarek, do you recommend routine herpes zoster vaccine before use of anifrolumab?
Yes, not just for anifrolumab, for all the biological therapy. I do, we have like a protocol. I put B virus, pneumococcal, herpes zoster, in girls under 16, papillomavirus, and influenza and COVID seasonal.
So the for
all biological, but not for the marts, only biological. Okay.
As per the ACR recommendations that patients with musculoskeletal rheumatic diseases should be vaccinated before the start of biological therapy. For the herpes zoster vaccine, it is recommended as early as 18 years for those with musculoskeletal disease. We have to end this workshop because we have a coffee break before the official opening of the Congress. We would like to thank AstraZeneca for sponsoring this workshop, for having the time, and the discussion was eminent professors. We are welcoming Professor Tarek in Cairo, and I hope you will enjoy the rest of your stay here. في coffee break، وبعد كده ان شاء الله الاوبننج بتاع المؤتمر بقيه الساينتفك سيشن. التايم احنا قدامنا ربع ساعه، coffee break ونرجع على طول إن شاء الله. Only 15 minutes for the coffee break.